Myself is Dr. Sachin. I am from Kokilabin Bhilbai Ambani Hospital from Mumbai. So, my patient, Mr. KP, 56-year-old male. My patient, Mr. KP, 56-year-old male, farmer by occupation, resides at Ayappakam in Chennai. He comes to dialysis center for maintenance hemodialysis twice weekly on Tuesday and Saturday since last 5 months. He is known case of hypertension, CKD stage 5 post-transplant. Sir, I would like to date back my history 20 years back. At the age of 36 years, in 2003, he was apparently well. One day, after returning from the work, he started with the symptoms of headache, uneasiness, profuse sweating, for which he visited emergency department of the local hospital. He got admitted in ICU. On evaluation, found to have raised BP of 200 by 100 mmHg, for which he required IV medication for control. He took 3 to 4 days to control the BP, and he was discharged on the oral medications. He says that all relevant investigations were done, they were within normal limit. He advised for the regular follow-up and advised for continuing medications, but he says that he took all medications for a few years, and he was after that he was non-compliant for medication. He started daily exercise, yoga, and also used history of use of alternative medications like Siddha medications over the period of 5 to 6 years intermittently. In the year of 2015, he again got admitted in the hospital in view of raised BP and left-sided weakness, which got recovered within the 24 hours. During this admission on evaluation, found to have deranged renal function with serum creatinine of 1.79 mg per dl. He also has been told that he was leaking some urine in the protein, some protein in the urine. On further elicitation, he gives history of mild pedal edema, increased frequency of urination in the night, easy fatigability. And there was no history of burning, micturition, fever, frying pan, hematuria, decreased urine output, joint pain, rash, chronic NSAID injection. He was advised for the kidney biopsy, but as he was started on antiplatelet medications, so kidney biopsy was done after 1 month of stabilization. Report was not available at present. He was advised for the regular follow-up and strict compliance of the medications, and his serum creatinine increased gradually over the period of 4 years, and he progressed to CKD stage 5 in September 2019. And he was asked for the AV fistula creation, for which he underwent the surgery, but AV fistula failed to mature. Then he was started on the maintenance hemodialysis thrice weekly from November 2019 with the access being right IGV curved tunnel catheter. He gave history of vaccination for hepatitis B, pneumococcal vaccine, influenza, and his residual urine output was maintained around the 800 to 1 liter per day. His weight gain between the two sessions of dialysis was around 1 kg. Post-HD weight gain was 44 kg. There was no history of any alarm during hemodialysis, no history of nausea, vomiting, cramp during hemodialysis, no history of any interdialytic hypotension or hypertension, any blood transfusion. He was started on erythropoietin injection once a week, 4,000 international units subcutaneously. He was planned for the living donor renal transplant with his elder brother was prospective donor, for which workup was done. His blood group was AB positive. He underwent ABO compatible living donor renal transplant on 21st 7/2022. He gives history of administration of costly injection, probably ATG, as an induction agent. Post-operatively, patient had good graft function with good urine output. He was started on the triple immunosuppression. After that, his creatinine reduced to 1.6 milligram from 4 milligram per dl within 3 days, and he was started. So then he suddenly developed decreased urine output, abdominal pain, distension, graft tenderness, post-op day 4, and his serum creatinine increased to 2.5 from 1.6 milligram per dl. He underwent imaging study and graph Doppler. Details were not available. He gave a history of surgical re-exploration also, which revealed intact blood flow. Post-transplant graft biopsy was also done, but his serum creatinine was increased to 6 milligram on day 6. In view of raised serum creatinine, he received injection steroid during hospitalization for 3 consecutive days, and his tacrolimus was withheld. And his creatinine value does not improve. He received 2 sessions of hemodialysis during stay in view of persistent rise in creatinine, and his urine output was reduced to the 700 ml to 1 liter per day. And he was explained about the poor graft outcome and need for further restarting maintenance hemodialysis. He was again started on maintenance hemodialysis twice weekly. On past history, there was no history of diabetes, ISD, TB, major medical or surgical history. On personal history, there was no history of any addiction. Bowel habit was unaltered. Diet was mixed. Sleep appetite was unaltered. No significant family history. On treatment history, he was on tablet Visolon 5 mg. On tablet mycophenolate sodium 250 mg 4 times a day, tablet Valgan cyclovir 450 mg once a week, tablet Bactrim DS for once a week, metoprolol 25 mg 1 BD, nifedipine 10 mg 1 BD, clonidine 100 microgram 1 TDS, furosemide 40 mg 2 BD, sodium bicarbonate 500 mg 1 BD, and erythropoietin injection 4K subcutaneously once a week. So I would like to summarize, sir. So Mr. KP, 56-year-old male, known case of hypertension since 20 years with non-compliant to antihypertensive, history of chronic use of alternative medications for 5 years. He developed probably TIA in 2015 during evaluation diagnosis of deranged renal functions. Progressed to ESRD in November 2019. Initiated on maintenance hemodialysis thrice weekly with dialysis access being right IGV tunnel cuff catheter. He underwent ARIO-compatible living donor renal transplant on 21/7/2022. Post-op day 4, his creatinine, within the 3 days his creatinine reduced to 1.6, but on day 4 it jumped to 2.7 and progressively increased, and developed allograft dysfunction from post-op day 4, underwent kidney biopsy and surgical re-exploration also, and was having the adequate blood supply and closure was done. Received IV steroids for 3 days. He is requiring now 2 sessions. At that time he required 2 sessions of hemodialysis also. Inform about the poor graft function, prognosis, and requirement of further maintenance hemodialysis in near future. Now he is on maintenance hemodialysis twice weekly with residual urine output around 200 to 300 ml per day. So that is the summary, sir.
What are the possibilities?
So, sir, my provisional diagnosis, my syndromic diagnosis is, sir, CKD stage 5 post ABO compatible living donor renal transplant.
What is that called? CKD 5?
Yes, sir, it is in stage
CKD 5?
T. Yes, sir.
Okay.
With accelerated allograft dysfunction secondary to query acute antibody mediated rejection, acute cellular rejection, query thrombotic microangiopathy, query acute cortical necrosis also. with hypertension, and I would like to divide my diagnosis in two parts. The native kidney disease being chronic tubulointerstitial nephritis, secondary to the chronic use of SIDA medication or alternative medications, or chronic kidney disease of
He had hypertension much
200 by 150
Yeah.
was the first
First
presentation.
presentation.
Yeah.
That is when he was 36 years old.
yeah.
He had
Twen-
hypertension.
26, 36.
36,
Yeah,
yes.
36 years. Yeah.
The SIDA medications came much later.
Much later.
Much later.
Yeah.
Right, we understand he was on SIDA medication.
Yeah. Yes, sir.
But somebody developing hypertension 200 by 100 at 36 years of age, that's a presentation.
Yes, sir.
You still consider only chronic tubulointerstitial disease? And it
See,
was also-
chronic glomerulonephritis can be a cause secondary to
Yeah,
IgA nephropathy or
Okay.
yes, sir.
So the native kidney disease here is unlikely to be interstitial disease, primarily.
Okay, sir.
It has to be a glomerular disease.
Sir, he can be a CKD of unknown etiology also, because
So let me ask you the definition of CKD.
Unknown etiology.
yes, sir.
What is the definition of CKD? Given this definition.
Yes, sir. So CKD of unknown etiology is defined as criteria for diagnosis of suspected case, probable case, and definite case. So suspected case, whenever the GFR is less than 60 ml per minute per 1.73 meter square, along with or urine dipstick positive for 1+ or more, with exclusion of diabetes, with HbA1c more than 6.5, with exclusion of the known causes of renal failure. Then in for the
Known causes of. Here, you feel that this is a glomerular disease. You
Yeah.
feel that, and there was some proteinuria also.
yes, sir.
Proteinuria.
Yeah.
So you feel that this is glomerular disease or CKD of unknown origin?
Or tubulointerstitial disease you said first.
Um,
In which
First-
category the blood pressure will be higher?
in glomerulonephritis, sir. Yeah.
Glomerular.
So chronic glomerulonephritis is most probable.
Could this
First-
be a primary hypertension also? Which
Yes,
is
sir, it
what
can
led
be.
Which is what led to, but what would be the cause of hypertension in a 36-year-old?
Yeah.
How common would be primary hypertension or secondary hypertension? So what are the,
So primary hypertension is very less likely, sir. Most probably, but they told that he was
at young age, obviously, I wouldn't say primary hypertension is uncommon. Primary hypertension can still be the common cause of
Presenting at
present
200 by 100
Yeah,
would be
would be
uncommon.
still. But the question is, secondary causes of hypertension will be much more prevalent in this group of patients, and one needs to look for those causes before you label that patient as a primary hypertension. So
Yes.
that's a statement which has to go along with at 36 years of age. It's not somebody who's at 50 years of age or so.
What are the reasons for 200 by 100 blood pressure at
Yeah,
36
at that
years?
36 years.
So, sir, it might be a renal artery stenosis.
Because of what? Renal artery stenosis at 36 years of age is what causes of renal artery stenosis. If it is renal artery stenosis.
So, in young age, sir, but it is less common. Fibromuscular dysplasia, but it is common in females.
Females.
Yeah,
Male.
male.
Okay, so what is the, could be the cause of renovascular hypertension?
So,
In Indian setting, yeah, so aortoarthritis.
aortoarteritis, yeah.
Non-specific aortoarthritis. But you, on examination, you don't know the examination. So, but history-wise, yeah. So aortoarthritis would be one such cause if one were to consider secondary hypertension. Any other?
Common endocrine cause. that is
yes, sir. So, hyperaldosteronism,
Yeah.
then
Pheochromocytoma.
Cushing syndrome, pheochromocytoma, main 1, main 2, hypothyroidism,
Hyper causes more.
hypo में hypertension.
So the
Any
other
drugs which can cause
cause.
or any addiction which can cause
Cocaine.
cocaine,
Yeah.
NSAIDs,
NSAIDs.
even cold medications, ephedrine, everything can increase the blood pressure.
So if you were to, glomerular disease is the other
Yes.
cause that you felt that that is most likely
Yes, sir.
cause probably for him. Okay.
Yeah.
So when you get a patient, you, in the immediate post-transplant period, you have graft dysfunctions.
Yes,
So how
sir.
would you proceed if you were the treating physician? So how would you proceed?
Sir, so initially, if transplant is within hours, then might be because of hyperacute rejection, because of preform antibodies, and if it is developing within.
So how does one prevent development of an hyperacute rejection?
So, sir, usually this is very less common nowadays because we do CDC cross-match test and donor-specific
When
antibodies.
do you
Also.
get a hyperacute rejection?
Whenever there is preform HLA antibodies are there, then we get the hyperacute rejection, sir.
And they have to be present in a significant
Significant titer.
titers,
Yeah, yes, sir.
isn't it? So usually your tests,
Right.
so what are the tests we can
What are the
emphasize it
immunological
again,
tests you do it?
although we have gone over it, but we can do it again.
First, this is CDC cross-match.
Okay.
Then donor-specific antibody.
In CDC only you can enhance anything,
Yes, sir. Flow cytometry.
No, CDC,
AG,
AHG,
AG augmentation. That will increase the sensitivity because
Okay.
sensitivity of CDC is poor.
Yeah.
Okay.
okay.
Then?
So then you do a flow cytometry.
Flow cytometry
cross-match, which is
cross-match.
more sensitive.
Yes, sir. And then the single antigen bead test.
Yeah, in some patients you might also, if you feel suspicious, then you will do a single antigen bead as well.
Yes.
So these days you should be able to pick up preformed antibodies,
Yes.
anti-HLA or donor-specific antibodies, and you should be able to prevent hyperacute or accelerated rejections and
Yes.
acute antibody-mediated rejections.
Hyperacute will be positive when you have CDC positive you are doing, then there is a higher chance.
Yes, sir.
So in this patient, you felt that there could be an accelerated rejection.
Yes, sir. So,
So now how will you confirm whether this is an accelerated rejection?
sir, so
You don't have access to what was done as a pre-transplant evaluation?
Yes, sir.
You don't have that?
yeah.
Okay.
So, I would like to go for the donor-specific antibody checkup and the kidney biopsy. So, to rule out the acute antibody-mediated rejection.
So what does
acute,
the kidney biopsy show in an acute antibody-mediated rejection?
sir, there will be peritubular capillaritis and C4D staining positive. So, according to BAM's classification, so,
So what are the histological characteristics of?
Okay, sir. Histological characteristic of acute antibody-mediated rejection are defined as the acute tissue injury with the three of the followings: with the microvascular inflammation, intimal arteritis, acute tubular necrosis without any other cause, and thrombotic microangiopathy without any other cause. So, and presence of donor-specific antibody. So, this should be the findings, sir.
C4D positive.
C4D positive, yeah.
Okay, so that's how you will diagnose acute antibody-mediated.
Yes.
So you will also do, in addition, you will demonstrate donor-specific antibody.
Yes, sir.
So in that, so
All ABMR C4D will be positive.
No, sir.
In what percentage of ABMR C4D will be positive? Or C4D will be negative in how many percentage of patients?
Sir, in many cases it will be positive, but only few will be negative.
what
sir.
percentage will be negative? That's why
It-
question.
If it is negative, then what are the reasons for negativity?
2 to 5% will be negative, sir.
Reasons, why is it?
Why it is positive?
Anybody else?
In ABMR,
ABMR.
why it is positive? C4D, why stain it is there? Why it is positive?
Yes, sir. So there will be a complement activating antibody interaction with the endothelium. So there will be a fixing of the C1q and there will be activation of in presence of complement factor 4 and 2 there will be a formation activation of the alternative complement pathway C3 and then
So
C4.
C4D negative means it is not complement fixing. So the antibody can act in different ways to damage the graft. So what are the ways? And how can you detect it? It can directly damage the endothelium, NK cell pathway. If the DSA is positive, then definitely.
Yes.
If the C4D negative, also DSA positive. But sometimes DSA is negative, then what do you think it is due to? Whether the antibodies are there, it can be all absorbed to the graft, whether it is possible.
Yeah, that is possible, sir.
Detect endothelial receptors like 81, 82 receptor antibodies.
Yeah.
So non-HLA antibodies.
Non-HLA antibodies, yeah.
Non-natural.
Any other
Non-HLA.
reason why C4D can be negative?
Yeah.
ABMR?
MIC, yes, sir. MIC A, MIC B, and
See, suppose you do a biopsy quite early, C4D may not be there.
okay.
Or if the tissue is very necrotic,
Yeah.
very bad anemia, may not be there. Of course, technical reasons could be.
Yes.
So if you have done a biopsy, aggressively done a biopsy very early, then it can be there. So it doesn't
Okay.
essentially mean it is C4D negative. Could have
Only
been
acute tubular injury.
Yeah. Why is it around the peritubular area? You're looking for peritubular C4D, why? Why not in the glomerulus?
Binding is the binding of C4D is very characteristic to the peritubular area. The binding is not that significant.
Covalent
binding. It's very related to the PTC area, but not the glomerulus.
So if the glomerulus is positive and then peritubular negative, then what it is? Is it taken as positive or negative?
But
In this patient, CNI dose was reduced.
It was stopped. sir.
What stops, sir?
Why?
So, sir,
What your conjecture? Why CNI was stopped?
so first thing, sir, as there was a rising creatinine, that CNI can cause.
This patient had oliguria, graft tenderness.
Yes, sir.
In spite of that, the CNI was stopped.
Yes, sir.
Why?
So, might be because of high.
From clinical point.
Yes, sir.
So what is the justification of stopping CNI?
So, CNI can cause vasoconstriction and then can cause the deranged renal function.
Not
in
deranged renal function. Patient who had graft tenderness and oliguria, do you think this corroborates well with CNI, classic CNI toxicity?
CNI
It's
can
not-
cause TMA, sir. So that can be a one reason. Thrombotic microangiopathy can be caused by the CNI. So in that case, we have to hold the CNI also. So that can be a reason.
So CNI was ultimately stopped.
So yeah, sir, it was stopped.
So-
It was not given for the.
So in that case, what could be the what could be the reason? Because this patient was treated in the line of ABMR.
Yes, sir, but for
See, ABMR being treated and side by side CNI is being stopped. What could be the rationale behind it?
If
They
you opened the
reopened it,
biopsy finding is not known.
No, so we don't.
They
Okay,
gave
leave
three
aside.
doses of
Regarding
methamphetamine.
transplantation, so
I
many
think
things have been
ABMR
asked.
most likely, the question of
About
plasma,
hypertension,
TMA,
history
but
of
they
plasma
didn't.
is
This
also
patient
not
had
there.
resistant hypertension.
Yeah, they-
yes, sir.
Initially, it's a prolonged history of resistant hypertension.
Yeah.
So how do you define resistant hypertension?
Sir, resistant hypertension is defined as when patient require more than 3 first-line antihypertensive agents, including diuretics.
A-type?
including diuretics.
At what dose?
At maximal dose. At maximal dose.
Tolerated.
Yes, maximal tolerated doses.
So,
yeah.
suppose a patient's blood pressure is controlled with 4 antihypertensives. Is it resistant hypertension? Yes or no?
No, sir. It is not.
It is.
Control.
Control. Okay.
It is. Now, by the revised diagnosis also, this is American College of Cardiology definition, recently 2018 I think. They said even if the blood pressure is controlled with 4 antihypertensives, including a diuretic, it is resistant hypertension. What is refractory hypertension?
When a patient requires 5 or more drugs for control of the hypertension, including diuretics, it is called as refractory hypertension. And many patients respond after addition of spironolactone.
I'm not asking those.
Yeah.
You just go about, you said one of the reasons could be adrenocortical hyperplasia or tumor, whatever, hyperadrenocorticism. How will you suspect and how will you confirm the diagnosis whether the patient has got hyperadrenocorticism?
So, yes, sir. So,
When will you suspect and how will you investigate?
so
You see, nowadays it has been found in a recent study that in 23% of patients who are supposed to be so-called resistant hypertension, they have actually hyperadrenocorticism. So it is coming up.
yes, sir.
So when will you start suspecting and how will you screen and how will you confirm?
Whenever the patient is having hypertension associated with the hypokalemia, then I would like to.
So hypokalemia is one suspicion.
Yes, sir.
In what percentage of patients of hyperadrenocorticism will get hypokalemia?
I don't know, sir.
Not even 20 to 25% cases. So then, what will be the screening investigation?
So, sir, yes, sir. So, serum aldosterone level, then aldosterone and plasma renin activity ratio.
Plasma renin activity and serum aldosterone. Okay. What are the values?
So, if
Plasma renin activity. What do you expect the plasma renin activity to be? But do you know it? If you don't know, you okay. If you
no,
don't
I
know,
don't-
if you are not sure, I'll leave it.
I'm not sure, sir.
Okay, fine. How will you confirm?
sorry, sir.
How will you confirm? How will you confirm whether the patient has got hyperadrenocorticism?
Yes, sir. So,
Hyperadrenocorticism
adrenal
could
venous.
be because of tumor,
Hmm.
which may be unilateral, bilateral. It can be because of adrenocortical hyperplasia. So, how are you going to confirm? No, if you don't know, I'll not ask. If you have not read it, I'll not go into the depth of all this.
Sir, I would like to go for the test like adrenal aldosterone.
No, if you are,
Venous
once again I
sampling.
tell you, in the examination also, it's very important. That if you don't know confidently,
No,
you
sir.
say, sir, I don't know.
No, I don't know
Then the
confidently.
next question will be asked.
Yes, sir.
So, because this part was not discussed. So many times you have discussed the post-transplant thing, and so I thought that I think this area we should discuss. That's the reason I raised this issue.
So if it is an ABMR in the biopsy, the post of day 4 or day 5, then how do you treat?
Yes, sir. So there are the two theories, two types of treatment. Either high dose IVIG or second will be the plasmapheresis with low dose IVIG. So mostly patients
What is
are.
the basis? Patient has an antibody, right?
Yes, sir.
So plasmapheresis will do that. What?
Plasmapheresis will remove the antibodies
Okay, so
from the.
plasmapheresis.
Yes, sir.
Okay.
Yeah, and the
What are
IVIG will.
different ways of removal of antibodies.
Yes, sir. So, plasmapheresis by membrane filter,
Okay.
then plasmapheresis by the centrifugation.
Okay.
Yeah,
And double filtration.
double filtration, immunoadsorption. No, sorry, sir.
Then IVIG.
IVIG.
How the IVIG will act?
So, IVIG is the immunomodulatory, and it will prevent the synthesis of antibody through it acts on the Fc gamma receptors
And down-regulates.
and it inhibits the complement cascade also. Yeah.
Any addition you want to give anything?
So
Rituximab
rituximab can be given or bortezomib can be given, sir. So more effective will be a bortezomib because it reduces the it acts on the plasma cells which can produce the antibody formation.
Dissection bortezomib is superior over rituximab or any other agent. Bortezomib trial what showed what? Beneficial or
No, bortezomib, no,
Not
it
sure.
not, yeah.
Yeah, theoretically, it looks like that bortezomib should work, but at least in the trials, it's not shown to be effective. So that's the problem with bortezomib. So theoretically, it is, what you said is right, that it inhibits plasma cells and plasma cells make antibodies and all that, but theoretically is okay. But at least in trials, comparative trials, it has not been shown to be effective. So rituximab still remains the drug of choice at the moment.
if it is a combined, you can use ATG also.
Yeah,
Yes, sir.
if
Yeah.
many times when you do the ABMR biopsies, on biopsy you find there is a mixed kind of a rejection. So you have an antibody mediated rejection, but you also have a acute cellular rejection. And then if steroids have not produced an effect, then you would use a thymoglobulin also in this kind of a situation, because you are losing this graft within 4 days of its implantation. So severely aggressive disease, so you would want to reverse it if it's possible. So therefore combination of therapies are used in these kind of situations.
So can we use ATG even if there is mixed, is not seen on biopsy, but if the graft is not responding, the steroid maybe, can we still give ATG?
Yes. What is steroid non-responsive rejection? What is the definition?
Yes, sir. So if a patient is given steroids for more than 2 episodes for the ABMR, sir, antibody mediated.
Is that you are given steroids. How do you classify it as steroid responsive, steroid non-responsive?
Yes, sir. So when after giving steroids, when creatinine is reduced to the baseline by at least by 25%, and
25%.
donor specific antibodies
How many days?
within
3 days, 5 days, 7 days?
within 5 days, sir. And donor specific antibodies also get reduced more less than 50%.
Donor-specific antibody is not in a steroid. So if it is steroid non-responsive, we can give ATG.
In fact, that was the indication for which ATG was approved by FDA initially.
Yeah.
The approval for induction came much later.
You said patient has given 3 doses of methylprednisolone and non-responsive. Whether you want to do a rebiopsy?
Yes, sir.
Which patients you do rebiopsy and why?
Sir, when patient is not responding, so for further course of management, I would like to do rebiopsy to see whether there is a treatable disease or patient has developed cortical necrosis. So for that purpose, I would like to do rebiopsy.
After how many days?
I don't know, sir.
So 3 months is
3
very
months
long.
is too long.
Too
In
long
about
by
a,
the
yeah,
time.
a week or so.
Every weekly.
Yeah, every week.
Every
It
week.
is 7 to 10 days.
Yeah, 7.
You need to do a biopsy to see. Sometimes the rejection may resolve. There may be an acute tubular injury.
Okay.
Then just intensification of immunosuppression, it causes more infections and other complications. If it is ongoing rejection, you will have to take a precaution and then intensify the immunosuppression. If there is a cortical necrosis, then you will have to talk to the patient, then aggressive immunosuppression is harmful.
Yes, sir.
The other important point which is not emphasized enough, I think, is every time, even many years later you treat an acute rejection, do give prophylactic treatment for prevention of infections, especially Like we use Bactrim and we use Valgan
Valgan,
cyclovir
cyclovir.
for during the initial period of transplantation. But when we give anti-rejection therapies years later, even then it is important to
give-
prevent these prophylactic. Antibiotics are important for prevention of those. So that's
Yes.
again many times missed by us, and we not as sort of, it doesn't get into our rhythm in that fashion, so it's missed by many nephrologists, so they don't give these.
Another important issue is sometimes the changes like cellular infiltration, tubulitis, these may be caused by, as Sir was telling, cotrimoxazole or trimethoprim sulfa. They can cause acute
Allergic
interstitial nephritis.
Interstitial
And
nephritis.
they are so closely mimic, they do mimic this particularly acute cellular rejection. So it's sometimes very difficult to distinguish between the two. So sometimes when we are at a loss exactly what has to be done, we withdraw cotrimoxazole and that does wonder. I mean, we have seen patients who have improved, which we are thinking and we have treated, it is not responding. So if say acute cellular rejection, we are treating according to the conventional line at not responding, then the logic is we have to escalate the immunosuppressive, whatever, treat in the line of giving thymo or whatever. Instead of that, you withdraw trimethoprim and the patients respond. So it is all acute allergic interstitial nephritis. The distinction may be if the infiltrate is by eosinophils, but many a time the pathologist fails to give us the clue whether these infiltrates are eosinophils or not. So they also are unable to distinguish between the two. So then we withdraw it.
Yes, sir.
Any other method by which cotrimoxazole can increase serum creatinine?
Yes, sir. It can cause increase in serum creatinine by reducing the secretion of the creatinine in the tubules. Competitive, yeah. Yes.
Any other commonly used drugs that can also cause this sort of reduction of creatinine secretion in the tubules? Very commonly used drug.
That is
What?
Yes,
cimetidine. Yeah.
Even the newer analogs like famotidine and all, they can also do that.
Cimetidine is much more.
Cimetidine.
Much more. The first reported was cimetidine.
Yes.
So if the graft is failing and you have continued on that, you have started on dialysis, how do you manage a failing graft? What precautions you take and what is the long-term plan?
Yes, sir. If patient is planned for the retransplant,
Right.
so I would like to continue his immunosuppression.
Which immunosuppressant?
He is on mycophenolate mofetil and oral steroids.
Suppose he is taking triple drug immunosuppression, his graft has failed, he is returning back to dialysis.
Yes, sir.
Then which immunosuppression you reduce and why?
So I'll reduce the mycophenolate first, then tacrolimus, and I would like to continue low dose steroids.
You want to completely take off the tacrolimus or reduce 50% and continue tacrolimus?
Reduce to 50%, sir, and
Mycophenolate mofetil?
completely I would want to.
Why you want to reduce? One is infection,
Infection risk.
second is anemia.
Anemia.
It's an anti-proliferative.
Yeah, anti-proliferative.
More anemia will be seen.
Okay, sir.
So why you don't want to stop all the immunosuppression? Immunosuppression increases risk of infections.
But
Why
it
you don't
could-
want to stop everyone?
Because sir, if we remove all the immunosuppression, it can cause sensitization and can cause the
What is
increase
graft syndrome?
graft syndrome.
What is it?
So failure of the failing graft is called that is the graft syndrome. Patient may have graft tenderness, fever, hematuria,
Reduction in the hemoglobin.
reduction in the urine output, fever. Yeah.
So it's all because of the rejection, ongoing rejection which is there.
Yes, sir.
And the antibodies will form or get increased if they have been, if an antibody has been formed against the donor kidney, then when you reduce immunosuppression, these antibodies will go. So second transplantation is going to get more difficult because you will have preformed antibodies now.
Yes, sir.
So which is what is going to happen. So you want to reduce the chance of preformed antibodies
Yes, sir.
for the second transplant.
Yes, sir.
So therefore, so tacrolimus probably is an easily and well tolerated drug even in, but you need to reduce the dosages, otherwise you will have, what are the complications of continued tacrolimus dosages in patients on dialysis? What could
So,
happen?
yes, sir. So, tacrolimus can cause new onset diabetes in
That's
patients.
one, okay.
It can cause
Much more commonly at that point of time.
hypertension.
Yeah, hypertension.
Yeah,
And it
hypertension,
is
tremors.
known to cause headaches,
Headache.
hypertension. So those are effects which are very commonly seen in patients who are on continued tacrolimus dosages
Yes, sir.
after failed transplants. But it's important to continue at least tacrolimus in modified dosages as well tolerated.
So this patient had a very early graft loss.
Yes, sir.
So whether you want to remove the graft or you want to keep the graft.
So, sir, there are the two options. Usually, if graft fails within 1 year, so we can immediately remove the graft. Or if there is chronic allograft rejection, then I would like to continue with the
And
graft.
this person had a graft loss within 10 days.
Yeah.
6 days he had problems. So he did not improve.
Yeah. So, sir, there is a risk of because after transplantation there is immediate formation of fibrosis and
That takes time. It's only 10 days after the transplant he had lost his graft. And he was dialyzed, and after that also he has continued to dialyze now.
yes, sir. So, graft nephrectomy can be done for this patient, sir.
No, obviously it can be done.
Yeah.
Should it be done or should it not be done? That's
It
the
should be
question.
done, sir.
It should be done.
Yeah.
Why? What is the advantage? What is the disadvantage?
So, advantage is there will not be a new de novo synthesis of antibodies
So
formation.
you are trying to remove the source of the antigen.
Antigen,
Which is
yes.
okay. So which is otherwise continued source of antigen presence in the body might continue to produce antibodies against it.
Yes,
So
sir.
that's one. Okay.
Yeah. And there is a second thought.
Immunosuppression you can reduce and take off.
Yeah, you
Yeah.
can take off and then you don't need to continue immunosuppression, which is a big advantage,
Yes, sir.
isn't it?
Yeah.
Okay.
So it's a late rejection and he has lost the graft. You want to remove or don't want to remove?
So I don't want to remove the graft, sir.
Why?
Because already there is formation of the antibodies, and there is the school of thought that all these antibodies gets absorbed into the graft.
What is that known as?
Thinking. Yeah.
Trojan horse hypothesis.
Yeah.
Basically, it absorbs all the antibodies,
Antibodies.
so it will prevent the rise in the antibodies.
Yes, sir.
So if you remove it, there may be rise in the antibody which may affect the new graft if you are putting.
Yes, sir.
Okay. Okay.
Thank you, sir. After a year, like it's more than 1 year, but we just continue oral steroid.
Oral steroid plus TAC, it's okay if you have an antibody, otherwise only steroid. If it is a long, it lasted for 5 to 10 years,
Yes, sir.
so then only steroid may work. If it is an antibody rejection or significant rejection, then you can continue a small dose of calcium.
Why this steroid dose will continue?
So probably since that kidney is there, it's
To prevent ureteral rejection. To prevent ureteral rejection.
So if any dialysis patient after transplant, if he starts getting fever, just look at whether he has stopped any steroids. Even after 4 years, 5 years,
Yeah,
they
yeah.
start getting fever.
Yeah, especially you keep on reducing their dosages from 10 milligrams, 7.5, then you go to 5, sometimes you go to 2.5 and see
2.5,
whichever. And then they suddenly start that they have tenderness in the graft or they have fever and usually you just increase the dosage. There are many patients who are even advised nephrectomy, and nephrectomy becomes a more difficult operation after many years of being transplanted, because there's a lot of fibrosis and all that, so it can be traumatic at that point of time. So just increasing dose of steroids for some period of time and then maintaining it at a slightly higher level would be enough to keep these patients okay. If you are not considering a second transplant, then probably small dose of steroids may be good enough to keep them. But if you are considering a second transplant, and that is an option which might happen in many of these patients, and now patients are also on the wait list for cadaver donation, then probably small dose of tacrolimus may be a reasonable thing to continue, because then you, especially if you haven't removed the graft in these patients, that would be important. Good.
The case is a 58 years old male, a diabetic, DSRD detected 3 years back. Left brachiocephalic AV fistula was created 1 year back. He presented with complaints of anorexia, nausea and vomiting. Back showed anemia, hemoglobin of 10.2, normal leukocyte count and serum urea of 111, creatinine 8.4. Electrolyte sodium was 90 milliequivalents and the potassium was 5.6 milliequivalents. He was initiated on dialysis.
You want anything to know? Anything else? Any other information you want?
Please use the mic. Record.
I would want to know the volume status of the patient and the blood pressure.
Okay. Blood pressure is 140/90 and he has 1+ edema.
And whether the fistula is functioning or not.
Fistula is
Fistula started 1 year back,
Created-
functioning fistula.
And the sensorium also, I would want to know whether he will be able, the sensorium of the patient.
Patient is conscious.
Sir, I would like to initiate dialysis via the fistula, a 2-hour
What are the
dialysis.
indications for dialysis in this patient?
Sorry, patient has uremic symptoms
Okay.
and has
Why do you say it is uremia? He has 8.4 creatinine.
sir,
50
anorexia, nausea and vomiting.
Sodium is 90. It might be the reason.
Sir, low sodium can also be due to uremia. He
90 milliequivalents. It's very severe hyponatremia.
Uremia causes hyponatremia, low sodium? I have not heard of.
Uremia protects.
it can be dilutional because of the volumes.
90? 90?
90 is quite low.
Very unusual.
120, 125 is okay. You can say that dilutional.
It's the other way. The vomiting is because of the
Hyponatremia.
Hyponatremia.
So bicarbonate is also very, very important, but is severe acidemia, and you have to correct both. It will be difficult. Volume excess, you said it's absolutely. If you want to treat hyponatremia by IV, then if it's volume overload, very difficult to correct.
Yes.
Okay. So there is no acidosis, only hyponatremia is uremia in your sense. Then which modality will be better for him? He has fistula.
Sir, hemodialysis by slow hemodialysis with a blood flow of around 150.
Why not peritoneal dialysis?
Sir, he has
Dialysis.
he has a functioning fistula. He has hyperkalemia
Hyperkalemia is only 5.6.
5.6, but
Why sir is asking about PD is because of the hyponatremia.
hyponatremia will get corrected slower with
So what is the lowest sodium you can get in the machine?
So 128.
129. So what is the difference between the two?
The range will be
Then how much you can correct in a patient who has hyponatremia in 24 hours?
8 to 10. This will be probably chronic
So what will
only.
it lead to? If you dialyze the patient unknowingly, dialyze the patient, what will happen?
Central pontine myelinolysis.
So we can probably start with a short duration of dialysis, like half an hour to 1 hour, with the lowest possible setting of the sodium.
And then with that we can.
Step up the duration of the dialysis along with monitoring of the sodium level.
Best facilities available, best do a PD, which will correct sodium.
Sodium slowly.
So slowly, then they give. Otherwise, if it is volume overloaded, you can give sodium and do an ultrafiltration only, which may correct. Or you can do only short duration, only 1 hour, not more than that. Otherwise, the shoot may be very higher, you may predispose the patient. Although the uremia protects from pontine myelinosis, still it can happen. Sodium is very, very low.
Can we use DDMP in this case along with dialysis? So that to prevent that overcorrection, of sodium along with dialysis.
See, that happens when the kidneys are good, functioning good kidneys. Unfortunately, that's all good when kidneys are functioning. In a patient who is on dialysis, none of these therapies would help. DDP and all those may not be very effective in that kind of situation. So you will have to use, if he didn't have a fistula, I think one would do a peritoneal dialysis, no doubt about it. So if he doesn't, so you could do even an acute peritoneal dialysis in him, and I would feel that once the sodium gets better, it's okay. But otherwise, if he doesn't agree and many people are not used to getting peritoneal dialysis and sit-up, then dialyze it very, very carefully,
First
very
correct.
slowly.
Only 2 hours.
First correct the sodium and then.
Correct the
if-
sodium.
Correct
and
the
then-
sodium if there is no
Or
other
the other
indication.
thing is to correct the sodium
Sodium.
first. But that's not going to be very easy in a patient
With
who is
ESRD.
on
Going to volume.
advanced, if is
So can we
going
do
to.
a short dialysis and for overload we can do a high. So you have.
You,
Yeah,
if the patient is volume overloaded, you can do an ultrafiltration.
Ultrafiltration.
That also will improve.
Yeah.
So how much, if you have removed for 3 liters of fluid, how much the sodium will improve?
5. I'm not sure.
So basically it depends on the weight. If it is 50 kilos, so if you remove 3 kilos, at least 4 to 5 milliequivalents it will increase. CRT, why you want to do unnecessarily so much of expenditure?
Yeah. No, do it effectively. I think do short dialysis.
Short
You should be
dialysis.
able to do it. 1 hour dialysis.
Because your
maybe
machine you
the
can't
first one.
reduce less than 128, 120. So then it's a problem. So you need to slowly increase the sodium. Either you can give only if there is a significant acidosis, then you can do only 2
Soda
hours,
bicarb
do an
or something.
ultrafiltration, and then correct the sodium by IV. Slow initiation. Don't go aggressively, and you can wait for a day if the sodium increases higher. You wait for a day, and then you can go ahead.
Actually, this patient, he did not do the hemodialysis. What we did was we put in a catheter bedside and we started him on PD, short exchanges. And the next day the sodium was, I think, 110 or 110 or 110, I think. But he was very conscious and oriented, so no seizures. We didn't find the need. Sugars were actually also a bit high. It was 300. It was a diabetic. That was also one of the reasons for the contributing to
To
the
hyponatremia.
So that's what we did in this patient.
How many of
Yes.
you can put in the acute PD and do PD? How many of you?
None.
Show of hands.
None.
In government
Very
teaching
few.
hospitals, on my.
Somewhere in, I think here probably in South East.
We also
North
do
is terrible.
occasionally
It's terrible.
hyponatremia. We do PD only.
Bad at it.
You do only PD.
Yeah, PD would be the best therapy.
Yeah, we used to do
This
PD.
patient.
We used to do PDD.
No,
So
we-
getting a solution is also and
we used to do PD like a bird. हमारे यहाँ hemodialysis मुश्किल थी PD होती थी. During our times हम तो PD acute catheter we used to even make our own catheters. वो
Just
जो
before
tubing
that,
of the
before you
hemodialysis.
leave, not, okay, no issues, please sit down.
उसमें बंद करके करो. Dialysis
Suppose-
fees PGI में बनता था ₹1 का.
2 patients have come. One
We would
patient
do 20. 10
has
to 20 in a day.
serum sodium, not this patient,
24 hours.
just hyponatremia. Serum sodium 110. No symptoms, absolutely normal. The other patient has serum sodium of say 122, and the patient has a little bit of altered sensorium or something like that. Which patient will you treat with sodium supplementation? A patient who has 110, absolutely normal. In the sense, I mean, there's no abnormality in sensorium. The other patient has 120 or 22. Symptomatic. What does it mean when somebody is symptomatic? Yes, this is very important. In acute hyponatremia, you have to treat the hyponatremia per se, because then hyponatremia will cause the damage. Whereas the patient is 110, asymptomatic, it's chronic hyponatremia, doesn't require aggressive treatment. Their aggressive treatment will cause the harm. This is very important while managing hyponatremia, whether the patient is symptomatic or asymptomatic, that will determine whether it is chronic or acute hyponatremia. And depending on that, your treatment strategy will be decided. Understand?
So sometimes the patient gets convulsions and he comes to you, your sodium may be a little bit higher by 4 to 5 milliequivalents because of the release of sodium by the muscles. So you have to, unfortunately it looks like it is better and it is not the reason. But again, if you wait, again it will go down. So post convulsion, you'll have to think that is possibly serum sodium earlier may be around 4 to 5 milliequivalents less.
So if it's a chronic hyponatremia and we are initiating on dialysis, maybe such a scenario, in that case also we have to be careful.
Yeah, acute you can treat it rapidly. Chronic you have to take
Be
time.
Very careful.
Chronic, you have to be extra careful.
Yes,
Oh, that's where the problem is. Acute, you could have gone and dialyzed if you were very sure that this was an acute hyponatremia. But this patient was relatively asymptomatic, so it looks like that it was more like a chronic hyponatremia or something. Yes, go ahead.
33 years old male, unknown, hypertensive and diabetic for 1 year. History of fetal edema in childhood, which is not evaluated. Now he is present. He also has history of hearing loss since childhood.
Any history of hematuria or frothing?
Yes.
Hematuria is there, right. Any history of visual disturbances? No. How is his blood pressure and diabetes control? Blood sugars?
That's not okay, 120.
All right. Any family history? There is family history in father, right. Any renal disease?
Or
In,
What are you thinking of?
I'm thinking about Alport.
hearing abnormality.
Hearing abnormality, sensory hearing loss. I would like to know urine routine examination.
So patients with Alports have very overt deafness like this?
Sometimes in later stages, it is usually mild, but they can develop severe sensory neural hearing loss also.
Generally it's very subtle.
So usually subtle, but sometimes
Usually
they
subtle.
might have been given any ototoxic drugs. to
You can always set your imagination.
They actually had one case that
Yeah,
he
it
don't
is.
understand he was given ototoxic.
Even furosemide can cause
Oh, yeah.
Furosemide.
very common, very common. Furosemide.
Aminoglycosides, furosemide
Furosemide
combination,
very common.
bad combination.
One of the judges in Calcutta, he lost because of furosemide, and he himself sued the doctor.
So you wanted urine routine exam.
Plus RBCs.
That report is not there here?
It's not.
She let out the diagnosis quickly.
Yes.
So how will you diagnose Alport short of genetic analysis? When will you suspect and how will you?
A patient, usually in our setup, they usually present late. So a patient with renal insufficiency, there is lenticonus, there is hearing problems, and if there is a history of family history, I would like to
How will
suspect
you look for lentigo?
slit lamp.
Your clinical examination, you are just, the patient is in your ward. How will you suspect lentigo? How will it look like?
From the side
Have you
we
seen?
from the side we pass.
Oil drop.
Have you seen in the ward?
In MBBS I have done. I have not done since then.
What is it?
In a
Classic
fluoroscopy
description?
only you can have a slit and you can see. So it looks like an oil drop appearance.
Yes.
So it will be like a droplet of oil on the glass. Yeah. Correct. And how do you confirm?
Slit lamp.
What are the ocular findings? Are there ocular findings in angina? Anybody?
Corneal opacities.
Right, anything else?
Retina.
Anything in the retina? The description of retinal flex.
Yeah.
It's supposed to be actually more characteristic of alcohol. What will be the, how will you confirm the sensory neural difference?
PT.
Clinical.
Renee's,
Tuning
Weber's.
Which
Frequency, yeah.
It will be lateralized or 512?
512.
Right.
So it will be lateralized or it will be equal?
Weber's will be bilateral will be equal to it won't be lateralized in
When
sensory
it is
neural.
lateralized, it's conductive.
It won't be lateral.
Not having thought of Alport and you biopsy, what are you likely to see?
Pass in
On the
No, no,
biopsy?
no.
On the
light
biopsy,
microscopy and then EM later.
On the light microscopy, is there something which suggests this could be low Alports?
There's I remember the basket weave appearance of the, but that
No,
is on
no, no,
electron.
EM.
But that
Light
is,
microscopy.
that is on electron.
Light
but if you
microscopy.
think
You ask for EM.
Light microscopy, anyone?
that is
Was
on
this a
electron microscopy.
Presence of foam cells,
Foam cells on electron.
Just
And
mesangial proliferation.
It's one of the
tubulointerstitial disease with some glomerular disease, and you will have
FSGS you can get.
FSGS like picture, and then you will have foam cells, predominant foam cells. So that makes you suspect that this may be. With the family history and all that, probably many times we didn't have electron microscopy available to us and for many years earlier.
And
But
thinning
now
and
that it is
thickening.
available,
Basement membrane you need to see in an EM.
yeah, basement membrane
membrane thickness.
is so variable thickness of
Variable
so
thickness.
thin and thick segments of.
Basket.
Basket weave
Since
appearance.
you got in electron microscopy, how do you differentiate between thin basement membrane disease and Alport?
Sir, in thin basement membrane will be uniform thickness, uniformly diffuse involvement, whereas in this will be a basket with thick and thin segments will be
So
there.
what's the normal thickness of basement membrane?
4 micron.
It's 373 plus or minus 20, and in case of female 325 plus or minus 20. Sir.
Okay. And what about the
Check.
thin membrane disease? Yeah, less than 250. Okay.
So if the child comes with the parents having hearing abnormality, patient has RBCs and 1 plus proteinuria. He is 10, 12 years old. What he will do? You do a biopsy. 24 hours is 1 gram proteinuria.
In the modern era, you do a biopsy or you will do some
Genetic analysis can be sent.
So rule out other causes.
Other causes.
Then confirm by ear and eye examination.
examination.
Then you can order for a genetic because there is no emergency in this patient. So only 1 plus or 1 gram proteinuria and hematuria, other things are controlled. Renal function normal. So you may do a genetic examination to confirm. May not do a biopsy.
So here this is Alport's syndrome, autosomal recessive. What's the usual?
Diabetic also?
He is diabetic
1
and
year. 1
hypertensive
year
from past
diabetes.
one.
Diabetes.
1 year diabetes.
How common is diabetes in Alports?
I do not know.
The parents are diabetic also? So
Father is diabetic, mother was not diabetic. Actually, was planning to do a transplant, preemptive transplant with mother as donor. But actually, the father didn't have the genetic
Autosomal recessive
So
carrier.
mother's genetic, because mother, when we did the urine analysis, had 20 to 25 RBCs in the urine. So we evaluated her genetically, so she's actually a carrier, so I don't think she can.
She can.
I don't know, that's a question.
Because she is in end stage at the age of 30 or something.
33.
So that maybe because of the dual insult, because in Alpors usually we see end stage renal disease a little late, not at the age of 30. Though it may happen, but usually we find it little later than 30.
What is the usual genetic predisposition? It is
Autosomal recessive.
What? It's an
X-linked, sorry,
X-linked.
X-linked.
So what percentage of
85% is X-linked.
one is a
X-linked.
X-linked disease, and the rest of them may be
Autosomal
autosomal recessive
recessive
and others as well. So it's autosomal recessive.
Recessive.
So how will it help you in finding a donor for? If it was X-linked, so who would be the most likely donor?
Oh, X-linked. Then father.
Then father would have been the most likely donor if it was
X-linked.
X-linked. But this is an autosomal recessive donor. So you will have to do a genetic analysis of the father and the mother, both of them. So if one of them has to be, and if siblings and others also, you will have to do them also included in the genetic analysis. So here the mother was done as a genetic. Father didn't undergo.
Father didn't have the genetic.
So
He
father
didn't
is
have.
Actually,
father is diabetic. Then whether you want
Father
to
is
take the
diabetic.
No, sir. No, sir.
So
there is no other family member donor. He is keen for donation.
Still we
So
do not take.
what would be the characteristics which will help you to accept him as a donor? He is what age? 55?
Yes, 55
Maybe 60 years or 55 years of age. So 60 years of age. So what are the things you will want if he is the only donor? And you can say that he might be accepted as a donor because he is the only donor. There isn't anyone else. And he is forcing you to accept him as a donor. Now what is it you will have which will tell you that he can go ahead, but will make you more comfortable that okay, maybe I allow him. And what will make you very uncomfortable?
No features of diabetic nephropathy.
So one is
no
and
protein,
organ damage.
no
And
proteinuria.
organ, not nephropathy. Nephropathy is totally out.
Okay.
So, and organ damage.
There no end organ damage.
Retinopathy,
Proteinuria.
albuminuria. Duration of diabetes?
Less than 5.
Less than 3
3
years.
years. Less than 3 years.
This is
Good
that
control.
American
So they have
Chasen
written more than
paper.
3 years.
Yeah, that usually.
So they have written more than 3 years because there is no.
Less than 2 OHs.
So fairly controlled of blood pressure.
Control blood pressure. In
Regular
fact,
follow-up
they have
by-
written probably he should not be hypertensive. He should not be hypertensive. This is a proposal. This is no guideline. This is a proposal made by a group of people in the US and is published in the Jason recently. So about I think a year back. So they have proposed that if at all, since worldwide many people with diabetes are accepted as donors, previously the guidelines had suggested not to accept diabetics
Only
as
the
donors.
Japanese have used
Yeah,
DNB
Japanese have
kidneys.
used, Japanese and some occasional case reports you find here and there, so a lot of people. And in India, many transplant programs are accepting.
Yeah, they are accepting.
They are accepting because we have a predominantly living donor transplantation and there are very small number of donors which are available. So you're forced to accept sometimes these donors. But you need to be careful because this whole program of live-in donation continues on the pretext that the donor is not going to be harmed by this. And here there are two potential harms that might happen. One, that
diabetic
obviously you
and
remove one kidney from a donor and you might have him back 10-15 years later asking for a kidney transplant himself or herself. Or second, you might give a kidney which is not good, which may be already affected by either diabetes or end organ damage and all that. So that's another issue. So you may not give a good donor, so you do not do benefit to either of them. So these are concerns about these accepting these donors, and we also don't have a registry of these donors. So unfortunately we have no data how badly are we accepting our donors. So we forget about the donor after that, and then we look after the recipients. We haven't looked after our donors at all. So that those are concerns which you should be looking at in these people when you look at donation.
What's the problem of transplantation in a patient who has Alpors post-transplant?
Anti-GBM disease might occur.
How frequently it is?
Less than 10%. Less than 10%.
1%.
You have anti-GBM antibodies in about 15% of
15%.
them, but symptomatic anti-GBM disease
1
occurs
to
in
2.
less than 1%.
Less than,
Less than
1%, right.
Why it will happen?
Why
Why
does
it
it
will
happen?
Deficient in the
Where is the genetic defect?
Collagen, alpha,
Collagen 4,
alpha,
Alpha,
type 4,
alpha
collagen
5, 4
alpha
and
5.
3. And where is the anti-GBM antigen?
Alpha 3.
Alpha 3.
3.
So, and these are helical. So they are intertwined with each other. So the expression of the anti-GBM antigen, the GBM antigen is not expressed in these people, in occasional these people. So it gets hidden. So body is not used to looking at that GBM antigen. When you put a new kidney now, and this antigen appears to be a foreign antigen, and therefore you have an antibody against this, and therefore you would. So there is some alteration in the expression of this antigen when you have this Alport syndrome, and the defects are very close to each other, 5, 3 and 4 and 3, and these are intertwined with each other. They're helical. So that's the reason why they would get this anti-GBM disease.
Next.
we have histopathology.
In Alport, according to the new Cath classification, if there is autosomal Alport syndrome, then son is autosomal like homozygous for that gene mutation, and if father is heterozygous, then how we should proceed for transplant if they are keen on transplant?
Yeah, that is not going to be easy. A distant relative probably may be a good idea, and it's going to be a difficult. If there is either a heterogeneous, both parents are heterogeneously affected by the disease, and then patient is homozygous, then probably a distant relative may be more.
And before transplant in Alports, is there any we have to confirm with the biopsy or with the genetic test is okay?
These days with the genetic testing, you will, especially unless the family history is such that you can confirm that this looks like an X-linked disease, that females have some expression, but males are the ones which are 2 or 3 family male members are affected, then you know that probably, and there isn't a female member affected, then you know that probably this is more likely to be an X-linked disease.
Sometimes
But otherwise you should be doing a genetic testing.
Hearing abnormality may be subtle.
Yeah.
So sometimes it may be difficult to
Yeah.
diagnose.
Some people don't have even hearing difficulty. This is not present in everybody. Lenticonus is not present in everybody. So you might have to do a biopsy to find out what it is, and then do a genetic testing. Fortunately, the genetic testing is available these days, but you will have to use many members also, even to understand as to what kind of genetic pattern. That's very important.
Especially the maternal uncles.
Yeah.
You must screen those people, because that's where
Yeah.
disease could be.
Because according to that classification, even carrier females are now as a disease zone.
Yeah, they
So
are.
in that only we cannot proceed for the transplant.
Sure. Very good.
So ideally, if they have crossed more than 55, renal function normal, no
Yeah, yeah.
cytopenia, only occasional RBCs or less than that, then you can consider. Otherwise, if they have already an hematuria, very difficult.
We just finished the water rounds now. Shweta. 27-year-old male, diabetic, hypertensive, no retinopathy, CAD post-PTCA. Baseline plan is 1.1 in November 2020. Urine analysis was normal in June 2020. This is the available past history. He presented with fatigue in December 2020. On examination, his blood pressure was 130 over 70. Otherwise, other than a mild pallor, everything else was normal. So this was his labs in Feb when he presented to us with fatigue. Hemoglobin was 12, count was 6,900, creatinine was 5, so his baseline was 1.1, potassium was 4, calcium was 9.8. His urine analysis showed pustles of around 12 to 15. Urine culture was negative. He had normal sized kidneys and his 24-hour urine protein was around 2 grams. Diabetic, 6 or 7 years.
So what's your clinical impression?
Actually, it might be February 21.
Suppose you see this patient in your clinic.
21 possibly. February 21 or 22.
Sorry, Feb 21.
No.
So what would you think of clinically? So you're sitting in the OP and you have all these reports and the patient with you.
Any other medications?
UP's albumin creatinine is 2.
2 grams.
HB is 12.
One is it is rapidly progression as compared to the diabetic. So it's a diabetic kidney disease or non-diabetic kidney disease? Non-diabetic kidney disease. These are elderly. So the reasons for non-diabetic renal disease is post-PTCA, but it's only the first. You don't have any, spontaneous is less likely. When you undergo any instrumentation, you can have it. So other areas you need to see, is there any digital infarcts or muscle or any other thing? If it is not, they're less likely. Don't have any acute, yeah? Is there any insult like loose motions?
No, sir.
Any
He
precipitating
actually just
factor?
presented with fatigue at that time.
Okay, any fever? Okay. Anything else you want? Serum albumin. Okay.
3.2.
Urine dipstick is negative for albumin and negative for urine protein is 2. So it could be a non-albumin protein that is.
So you want to ask for total proteins? It's only albumin is.
So like any non-albumin proteinuria like all the paraproteins.
Okay.
If that is the probably we should keep with electrophoresis.
Serum protein electrophoresis.
Electrophoresis, light chain assays, immunofixation. So basically, we need to know whether there is any monoclonal protein, that the type of monoclonal protein, whether which particular light chain is causing it.
No, you must have some clue first. You can't order this entire battery in one step. Being concerned this is renal failure.
Yes.
Just one thing, myeloma with hemoglobin 12 gram. How many cases you have seen? I'm yet to see any patient myeloma presenting with a hemoglobin of 12 gram until the patient is being transfused.
Rajiva is laughing and she's saying this will turn out to be a one month.
Yes, only one case I have seen. But the fact is, somebody comes with 12 gram hemoglobin, I am the last person to believe that this patient is suffering from myeloma. But clinical medicine is always some surprises. But if somebody comes with a hemoglobin of 12, and if somebody in the examination tells the diagnosis, the possibility is myeloma, I am not going to pass him in the first go.
In the examination,
It should not be the first diagnosis.
Yes?
It should not be the first
Yes, it
diagnosis.
should not be the first
The
time.
elderly man came with fatigue and there are pus cells in the urine.
No, if somebody says myeloma, my first impression will be the registrar has said, we told the candidate that this is a case of myeloma. ऐसे ही present कर दो. Yes, that's true, because sometimes the candidate is biased with the diagnosis from the very first go.
So what will you, so we consider that this may be multiple myeloma, this may be anything else, volume depletion, we don't know yet, but there isn't.
BP is 130 by 80 and low
BP is-
edema, and pulse rate is also reasonable.
Okay.
You see, urine pus cells were 12 to 15.
But
So
no
you-
culture.
No,
Culture is
no culture,
negative.
but sometimes analgesics, they can cause so-called pus cells are
Drug
actually
induced.
eosinophils.
Drug induced.
induced. So it could be drug induced also. So if you ask me, interstitial nephritis is a more likely diagnosis rather than those far-fetched diagnoses.
Yes.
Yeah, I
Prior
think,
medications,
Yeah.
Yes,
ACE
prior
inhibitors
medications.
or,
so you have to look at differential diagnosis in this patient. So drug induced interstitial disease. Anything else?
So he was having weakness, urinary fever, and I think doctor has given any antibiotic. So that can be a precipitating factor for this to cause an acute interstitial nephritis. Or for a weakness he has taken NSAIDs, which further causing him with weakness.
Even
the drug history is
indigenous
mostly-
medicine.
indigenous
Indigenous medicines.
So, just for the perspective, it was around 10 days before he presented to us. He was weak, but he had taken some amount of Siddha medications for 2 weeks. So when we did a biopsy for this patient, actually, we actually found an AIN. His creatinine had gone to 7 milligram per deciliter. We started him on a low dose steroids, with which his creatinine came down to 1.2 milligram per deciliter. He was doing well. He was following up with me actually. Then around a year later, he came with some back pain and a repeat creatinine of 6, which was again rapidly progressing, and this time he was very sure he did not take any medications, nothing.
The previous creatinine came down to what?
1.2. So he was doing well, again came with an RPRF a year later. So that time actually
That time
I
what is the
tried,
hemoglobin like?
that time it was 8.
Yes.
And his
Now
creatinine-
I agree. Now I agree. So 12 gram with urine pus cells, my first diagnosis will be AIN, and that proves. And with therapy, the creatinine came down to 1.2. That almost confirms that it was a case of AIN. And now comes with a hemoglobin of 8. Okay, I agree that it is myeloma.
So the hemoglobin, I think they put it somewhere here.
Yes.
We made a graph, we thought we publish it, to be honest. So 1 year later he came, and that time he had his calcium was 11. So, and he had a back pain. So when I did a MRI, it was a D12 fracture. So again I biopsied him. That also showed only AIN. There was nothing, no fractured scars, nothing.
But did you do the stain for kappa and lambda, and that was all negative?
It was not light chain
So not
restricted
that-
on biopsy. It was
on
still AIN.
Okay.
But the free light chains was extremely high. Lambda was very high, and SPEP M was positive. M band was there, and I referred him to the medical oncologist. They did a bone marrow biopsy, which is a plasma cell leukemia. So, so like a myeloma, this one. So it was started on bortezomib, cyclophosphamide, and dexamethasone. He responded well, and creatinine came down to 3, and he went off dialysis. Now, actually, currently, what has happened, he has become resistant to that, and he is on pomalidomide, dexamethasone, and cyclophosphamide, but still off dialysis. Almost 2 years now. Now he has protein, I think, no, he never had proteinuria. Never had protein test. Yeah.
And that was an acute event probably of the
Yes,
interstitial
when
disease.
you have cells, you may get a little bit of protein in the
Yeah, some amount of proteinuria occurs in interstitial disease as well.
So if these pus cells are actually eosinophils, so how do you stain them?
Which stain you do it?
Which stain do you do for eosinophils? So for eosinophil, which stain you use?
Anyone?
And Jimsa also you can use.
Jimsa we used to do previously, now it's Hansel is standard.
So if it is eosinophilia, you need to
interstitial
interstitial nephritis is right. You can treat with steroids if there is a need. It's not coming down after stopping the insult.
The recent reviews have mentioned that eosinophiluria
Yeah.
should not be given importance.
Yeah,
Yes,
yeah,
that's true. Yes,
true.
yes, that's true.
Anyway, for the exams, you have to say.
No, around 15 to 20%
Yeah,
cases you
Graft
may
biopsy
get.
also eosinophil. They used
Yeah,
to give
yeah,
importance.
yeah.
Now they have taken out.
Yeah.
In 15 to 20%
The
you
prevalence
get.
is so, the prevalence is so small actually that you can't base this on.
No, in
Eosinophilia, it's not significant.
Don't say it in the exam. For the exam, you must say cancels the injection.
In India, we nowadays see so many cases of this interstitial nephritis because of indigenous medicines. It's rampant.
Indigenous medicines and some allopathic medicines as well. Now,
Yes,
oncomedicines, especially the checkpoint inhibitors and all, so you see a lot of interstitial nephritis now with the checkpoint inhibitors.
There are papers also coming in journals, checkpoint inhibitors and
Dr. Mohit. So this was his biopsy actually. This guy. What's that?
Yes, ma'am.
25-year-old, he is a PhD student. He presented with headache and with a mild blurring of vision. He had history of OCD on behavioral therapy since 5 years. History of kidney stone 2 years back, needing URS and laser. Any other?
Student headache, no breathing difficulty, blurring of vision, history of OCD and behavioral therapy since 5 years. 3 years back. Ma'am, history of any like recent fever or fever and any hematuria, nothing, and any frothy urine? No. Okay, ma'am.
I would have asked for headache and blurry vision at least. Is he
type-
on antihypertensive
anti-
drugs, blood
okay.
pressure? those
Okay,
would
I
be-
was waiting
anyway,
for
now
that. Yes, sir. Yes,
And
sir.
Now the
also
blood
Yes, sir.
levels there,
Headache is
smoker,
there.
non-smoker, taking any
Yeah.
Polycythemia
any,
or-
pills for any rhinitis or anything,
Okay, sir. Yes, sir. And
analgesics.
analgesics, yes, sir. And no papilledema. This. Okay. So there's two.
So he had high blood pressure, no fundus,
No papilledema.
no papilledema. Generally, examination-wise, it was normal except for the high blood pressure.
Okay, so high blood pressure.
So if papilledema is not there,
Yes, sir.
that doesn't rule out hypertensive changes in
Mm.
it, because it is only grade 4.
Yes, sir.
So you may have mild changes,
Mild
that's the
changes.
catch.
Yes, sir.
If somebody says no papilledema, that
But what are
doesn't
the
mean
other
that there is
findings
no
of
hypertensive
hypertension?
changes in the retina.
Yes, sir.
She is smiling.
So what about the vessel wall? Fundoscopy or is any hard exudate?
Yeah, any exudates or is there any exudates present on the fundus? There are hard exudates are there, and
Yes,
ma'am,
ma'am.
so hypertensive retinopathy is
So what are
there.
these hard exudates?
So basically fibrin and
Yesterday we asked soft and hard in my, so I asked yesterday, what's the difference between soft and hard exudate?
Soft is nerve fiber infarct and hard exudate is cholesterol deposition with the refract.
yes, sir.
Yeah, some protein leakage along with fibrin and all would be, and soft are,
Nerve fiber infarct.
yeah, they are
Some have
usually,
worse prognosis.
Yeah, yeah.
Worse prognosis.
they are infarcts basically, the infarcts.
And okay, so, ma'am, sir, any investigations do we have? Okay, but non-obstructive keratinoid bicarb, there's hypokalemia, Doppler concentric mild.
Analysis was normal.
This was normal, ma'am. Okay. So, potassium was this bicarb is alkalosis, renal calculi.
Sodium 140.
Sodium, potassium is 2.8 milliequivalents, it's given as, that's a milliequivalent,
Magnesium is
2.8.
normal, phosphorus, calcium there.
So she's got,
Stones.
he, na? Male,
He is different. He's a young male.
Young male,
young
okay.
yeah.
Hypokalemia
Hypokalemia.
with retinopathy. And bicarbonate, which is metabolic alkalosis, with the creatinine of 1.8.
1.8. Little syndrome, I'm thinking on lines of that, maybe. Around that.
Anji, renal artery Doppler normal, hypokalemia, hypertension.
So, Gentleman syndrome, sir, I'm confused, just one second, sir. Liddle syndrome, I would like to.
अरे भैया उससे कॉमन
अभी सर ने कुछ बोला ना,
अभी तो बात कर रहे थे.
मैं अभी बोला था
hyperaldosteronism.
Okay, sir. Yes, sir. That
Hyperaldosteronism.
will cause hypertension, hypokalemia, as well as alkalosis. Yes, sir. Yes, sir.
He was telling you that this prevalence is 20 to 30%.
30%. Yes, sir.
लिडल सिंड्रोम कितने देखे हैं तुमने?
नहीं देखा सर.
तो ये लिडल सिंड्रोम कहाँ से आ गया बीच में?
Hyperaldosteronism would be the
Common
reason.
things first, right?
You are just discussing
Yes, sir. Yes, sir.
previous case.
Yes, sir.
So
Secondary causes, it is coming up like that.
yes. So you will consider
Hyperaldosteronism. Yes, sir.
Okay. हाँ जी. अब क्या मांगोगे?
And
आप
what
बताइए
about
ना.
why these stones? A patient with hyperaldosteronism. Why so many stones?
हो रहा है. So can't think about it right now.
Go ahead.
So what's the next thing
Yes,
that
sir.
you will? Differential diagnosis.
Yes, sir.
तो आपने एक तो कहा कि adrenal
Renal disorder है sir. Besides that,
renal artery
renal artery stenosis could be the another one.
Doppler
Doppler was
but
normal.
still-
Yes, sir. Yes, sir.
Still,
हाँ.
it could happen.
Yes, sir. That could be the
You
other thing.
require a very good ultrasonologist
Yes, sir.
to interpret Doppler. So Doppler, based on Doppler, you can't totally rule out renal artery stenosis, is it?
Yes,
So
sir.
you will still keep that in.
Yes, sir.
Anything else?
Calculi and this. Sir,
What are the other causes of hypokalemia in patients with hypertension? Which may be more
Sir,
common than
sir,
the two causes that we have discussed.
diuretics sometimes
Yeah,
can
diuretics,
lead to
yeah.
the
So
same.
sometimes diuretics
Yes,
can
sir.
lead to. What happens when you give, say, an oral diuretic? So do you find hypokalemia more common with loop diuretics or maybe a distothiazide or anyone?
More with the thiazide, sir.
More with thiazide.
Thiazides.
So you give thiazide to a person. What happens to potassium after, say, 1 week later, 2 weeks, 4 weeks? What happens?
So it initially there is a decrease, and then over the time it plateaus and can normalize.
Over the time it normalizes.
Yes, it normalizes.
They achieve
So-
a balance of
Yes, sir.
potassium.
So it says that we should keep monitoring. We can just repeat it, and if
But usually,
yeah.
unless there is another clinical event, something
Yeah,
which
then we
aggravates
should
hypoglycemia,
stop it.
otherwise, usual patients on long-term thiazide diuretics probably will have a balance. So hypokalemia does not persist.
Yes, sir.
Initially, you will see hypokalemia.
Yes, sir.
Yes. So anything else? So diuretics could be other causes.
Yes, sir. Hypertension.
What's the
So-
corrected calcium in this patient?
Albumin.
Albumin is the
Corrected was also 10.2.
10.2, okay.
Albumin was 4.
4.
So it isn't hypercalcemia.
Okay.
It's not hypertension.
And what's the serum uric acid level?
Uric acid.
4.8, sir.
That is also
Uric
fine.
acid 4.8.
Okay.
Sir.
आगे क्या करेंगे आप?
Actually, what we did, so we asked our doctor, a junior doctor, to send plasma renin activity.
I was about to ask that. Renin level is there, ma'am?
But unfortunately, they picked the
Around that was
RDA,
what?
and that was 0.004.
Suppressed.
Yeah. So that is, so they did it. So you want to know the
So
So
So-
you did the RAA then?
Renin,
And the RA, this ratio?
no,
I was about to ask, is the ratio, the ratio?
Ratio was 0.004.
So that's, would be.
So was low.
If PRA is so low, the
Yes, sir.
diagnosis is almost confirmed.
Mostly drug induced, then I would like to know. Oh, sorry, sir, I mean, it would be hyperaldosteronism. That,
Yes, I mean, PRA is so suppressed.
I mean,
that
if it's
diagnosis-
suppressed, then it is
With a high
hyperaldosteronism. I thought it was high,
aldosterone
sorry.
level,
The ratio is low, yeah, so then it is hyperaldosteronism.
Renin
Yes.
levels will be low.
Yes, sir.
So
Yes, sir.
suppressed.
Yes, sir.
So how would you do this renin assays and all? Is there a method in which you think, or you can go in the raw and take the samples and say, okay,
What are the precautions,
Yeah,
which,
so what-
which medicines
so-
you will discontinue,
Ah.
which you will continue with, while sampling, what precaution, how will you check?
I'll have to read that, sir.
You have to read.
Oh,
That's
yeah.
good.
No, I think it's
That's
important.
good. Yes, that's good.
It's important. It's important to know
I'll
because
do that,
sampling
sir.
is important in this.
Some of the medicines you have to discontinue, some of the medicines you can continue.
Sir, RAS inhibitors, all the RAS inhibitors we have to stop, the beta blockers have to be stopped.
be stopped, hydration status,
And yeah, it should be euvolemic.
and lying status or standing, position of the patient.
Yes, sir.
30 minutes rest.
Yes, sir. It should not be standing. It should be like lying on a bed, like sir mentioned, about 30 to 40 minutes of rest. And off ACE inhibitors, ARBs, beta blockers, at least more than 48 hours.
I'm telling you, the blood pressure is very high, very difficult to.
Yeah, then it becomes difficult, sir.
No, not 48 hours, 2 weeks.
Okay, 2 weeks. Sorry, 2 weeks, not 2
Minimum
days. 2 weeks. Okay,
And
sir.
some of the newer MRIs, 3 weeks.
Okay.
So how would you, so what else would you do? You will do an aldosterone level.
Yes, sir.
Okay.
And renin level, aldosterone levels,
CT scan.
CT scan. Yes, sir. And
MRI or CT.
But why this stones, I am not still convinced it is stones.
No. I think they are just.
Incident.
Could be incidental.
finding.
Nephrocalcinosis.
No, so why
Nephrolithiasis as a.
calcium is normal and other things are normal?
the stones are there, but yeah, multiple times.
Yeah, nephrolithiasis as a incidental.
Incidental.
So if you find that there is, so what is the likely chance that you will find something in the adrenal?
So adrenal adenomas are possible, and in about 20 to 30% of the patients, the adrenal adenomas are the finding. So ultimately, then we have to decide whether the resection of the adenoma has to be done or not. First of all, like if there is uncontrolled high hypertension, so again the class of antihypertensive that we can now use should be should not be the ACE ARBs or which are involving this axis. So if the blood pressure is still not controlled, ultimately we'll have to remove the adenoma.
Bilateral, then you can remove it. If
Yeah,
it is bilateral hyperplasia,
yeah, then we have to avoid doing it, sir.
Then if you have to use anti-aldosterone drug,
which
so
one?
which one would you use and what kind of dosages do you require to control blood pressure or to produce adrenal
Yes, sir.
suppression?
So ARBs, one second, sir. So is
Anti-aldosterone.
Achha, sorry. So spironolactone and spironolactone can be used, eplerenone can be used, and yes, sir.
Which one do you prefer?
Sir, the preferred one, sir. So the eplerenone, the one which is more preferred, it will be spironolactone, sir. Spironolactone.
Why?
Sir, it is due to the fact that.
What is the efficacy of both?
So spironolactone has higher efficacy as compared to eplerenone. It was just that, sir, eplerenone is more favored if there is side effects of spironolactone like gynecomastia, hyperesogenic conditions, then we might go with eplerenone, but otherwise spironolactone is the one which is more preferred.
What's the usual dose which is required to produce a significant?
Yes, sir.
What is the dose of spironolactone which is required?
Average dose required to produce this suppression of
25 milligram
Sir,
BD, TDS, 100 milligram, 50 milligram.
25 BD to 50 BD is
Mud dose is 100 milligram.
okay. Okay, sir. 100 BD, sir.
100 milligram, 50 to 100 milligrams
Okay,
twice
sir.
daily.
Okay, sir.
Would be required to produce. Usually higher dosages, something like 200 milligrams or so, aldosterone. That's why the side effects are fairly common when you use these drugs. So adrenalectomy, whenever it's possible to do,
We should do it, sir.
standard of care for this.
Yes, sir.
What about the newer MRIs? Can
Sir,
you use them?
the newer MRI, sir.
In this indication, have they been tried? Not yet.
Not right, sir.
Okay, ma'am.
Okay.
Any other
Thanks.
case? It is a good case.
Okay, okay. Okay, yeah, we can do combined. Yes, that would be good.
But you should.
Mumbai. Sir, I will start the case. My patient is, sir, 36-year-old female, resident of Dhaka, Bangladesh. She was staff nurse by occupation, Muslim by religion. She has recently done her transplant. She came for follow-up. She was asymptomatic at present. I would like to start the case when she was first time symptomatic. She was first time symptomatic in August 2021. That time she had her pregnancy. She was 4-month ANC, registered at private hospital at Dhaka with regular ANC follow-up, and each visit she has told that she had normal blood pressure. When she was first symptomatic, she had history of pervaginal leakage, which was watery, non-bloody, and non-painful. She also had history of fever with chills, which was high grade, continuous. So for this complaint, she went to the private hospital. She didn't have any issue of burning during maturation or decreased urine output, no issue of pain in abdomen, vomiting, no issue of yellowish discoloration of eyes and urine, no issue of cough, cold, no issue of altered sensory convulsions. So she was admitted. She was investigated. She had actually that time hypotension. She was started on inotropic support that time. She is well educated. She knows all the medical terms. She was started on noradrenaline as by her. She was told that she had rupture of membranes and subsequent loss of product of conception. So she was on the basis of investigation, she was told that she had high leukocyte count, low HB and low platelet count. So she was started on antibiotic that time. On subsequent days, her condition was deteriorating in the form of decreased urine output. She had developed bilateral low limb swelling. She also had palpitations, breathlessness on exertion initially. It was progressed to breathlessness at rest, and she had anasarca also on day 4 of admission. She also had anuria on day 4 of admission. So this time her blood investigations were again done. So she was told that she had low hemoglobin and her creatinine was 3.5. And she was actually told that they need to start on hemodialysis due to renal dysfunction. So dialysis was initiated through left femoral catheter, and on dialysis she received 2 PRBC that time. So she received daily SD for 3 days, and then after that 3 times a week. So this symptomatically she improved with the dialysis and antibiotic treatment, but output was not there. So dialysis was continued with interdialytic weight gain of 2 to 2.5 kg. With after 1 week she had issue of fever with chills on dialysis. So her blood investigations were again sent. Blood culture was sent. So a blood culture report came after 4 days, and it was showing some growth, and which was sensitive to tigecycline. So she was started on tigecycline injection, and so that femoral catheter was removed, and right neck tunnel cup catheter was put. And her in subsequent days her left distal AVF was also made. She received tigecycline for 14 days. On day 20 of admission, she was started having urine output. Initially, it was 30 to 40 ml. So it was gradually improved to nearly 500 ml at the end of 1 month, and nearly 1 liter at the end of 1.5 months. But her serum creatinine was stuck down to at the level of 7 to 8, and she was taking hemodialysis thrice per week. She was also taking injection erythropoietin 4,000 international twice per week. Had also received vaccination against hepatitis B, influenza and pneumococcal vaccine. So she was discharged after 1.5 months in stable condition and asked to take dialysis from outside twice per week because her output was good. So patient was taking twice a week dialysis from outside with she was told that she has renal dysfunction. Her ultrasonography was also done in the hospital. She was told that her kidney size were borderline and actually biopsy was not possible because kidney are not biopsiable that time. So she was taking dialysis twice a week from outside with interdialytic weight gain of 0.5 to 1 kg with no interdialytic complication, and she was using dialyzer only once. After 3 months post-abortion, she had history of fever with chills on HD and was admitted in same hospital and was again evaluated. Blood investigations were also sent. She had hypotension requiring inotropic support. And on blood investigation, she was told that she had high leukocyte count. She was started on antibiotic. After actually 3 days of antibiotic, she is still on inotropic support. So decision was made to remove her TCC, and it was removed, and right femoral double lumen catheter was put. After 3 sessions of HD through this right femoral DLC, actually her output was nearly 1.5 to 2 liter and her serum creatinine was 3.5 to 4 milligram per deciliter. So actually their physician want to observe her for need of dialysis. So her dialysis was stopped, and after 4 days of treatment, her creatinine was in between 3.5 to 4 milligram, and her right femoral DLC was removed, and she was discharged after that in stable condition. So she was at home for nearly 1 month. After 1 month, she had history of multiple episodes of vomiting, history of headache. So she was again admitted. This time she didn't have any issue of decrease in output, no issue of swelling of feet, no issue of burning during menstruation, no issue of fever, cough, cold, no issue of blurring of vision, giddiness, convulsions. So she was again evaluated. Her blood pressure was checked. It was 170 by 100 mmHg, and she was started on antihypertensive tapnigardia 10 mg BD. She was told that her serum, her blood investigation were done. She was told that her creatinine was 7. So need to start on hemodialysis again. So this time hemodialysis was started through left distal AV fistula, which was done in the first admission only. So she was started on dialysis. After 3 dialysis, she was discharged and told to take dialysis twice per week. So she was regularly taking dialysis twice per week with no interdialytic complication, with interdialytic weight gain of 0.5 kg, with residual urine output of 1 liter per day, and she was using dialyzer once only. She was counseled regarding live-related kidney transplant and cadaveric transplant also, but she was willing for live-related kidney transplant. Actually, her mother came forward as a donor, so mother's evaluation was started. Patient's blood group was B positive. So mother was hypertensive, was on only one antihypertensive, type amlo 5 mg OD. But actually her blood group was A positive. Patient was counseled regarding ABO incompatible transplant and risk related to it. So patient was not willing. So she had younger brother. His evaluation was done. His blood group was also AB positive. So it was also cancelled. She didn't have actually her father's death was there 2 years back due to COVID. She didn't have other siblings. Her grandparents were above 70 years, so they were also. So her cousin from maternal side came forward as a donor. He had B positive blood group, so he was willing to donate So his evaluation was started, but during evaluation, actually for kidney transplant, she was referred here in Mission Hospital, Chennai. So during the evaluation, during her routine investigation, her blood tests were done, and she came out to be hepatitis C positive. So her HCV RNA was done. So on it was very high, titer was very high. So she was started on anti-HCV treatment. She had taken her treatment for 3 months. Actually, for HCV, she was HCV RNA positive. So her ultrasonography of liver was done. It was told to be normal. So her HCV RNA level was checked after 3 months of treatment, and it was not detected. So her transplant evaluation again started. She was told that her donor's kidney function was good, and she was about to proceed for liver-related kidney transplant. Legal actually workup was done, and prior to transplant her HCV RNA was done. It was not detected. So her actually transplant was scheduled on 15th May. Prior to transplant, one special test was done. It is her blood group and her blood and donor's blood was sent for cross matching. It was told that it was negative. 1 day prior to transplant, she was started on tablet tacrolimus 1.5 milligram BD and tablet mycophenolate mofetil 500 milligram TDS and tablet predni 1 milligram per kg. On the day of transplant, she was started on one costly injection. She remember it. It was anti-thymocyte globulin. In the morning, it was started, and injection methylprednisolone was given in the morning. So on table post transplant on table urine output was there. Early she remembers it was 700 to 1000 ml on day 1, and actually she remembers her creatinine was 2.5 prior to transplant, and on the day of transplant it was dropped down to 1.8, and on day 2 it was 1.4. On day 3 of transplant, she noticed she had headache, giddiness, and palpitations. So she was evaluated. Her blood investigations were sent. Actually, she had low blood pressure. So IV fluids were started. So she was told that she had drastic fall in hemoglobin. Prior to transplant, it was 10.5, and on day 3, it was dropped down to 6.7. So there was no issue of decrease in output, no issue of pain in abdomen, no issue of nausea, vomiting, no issue of burning during maturation, no issue of breathlessness, orthopnea, no issue of fever, cough, no issue of pain at the suture site. Was told that actually CT scan need to be done to rule out the internal bleed. So CT scan was done. So on CT scan she was told that there was venous leakage at the anastomotic site. So that time patient was taken to OT immediately, and some operative procedure was done that time, and she was transferred 1 point PRBC after that. After this, she was shifted to transplant room, and she was monitored. She was already started on antibiotic. Her actually TAC level was done. So initially it was, she remembers it was 4.7. So her initial dose was 1.5 milligram BD. It was increased to 2 milligram BD. And again TAC level was repeated after 5 days. And repeat TAC level was 4.5 milligram. And dose was again increased to 2.5 milligram BD. Then third TAC level was done after 1 week. It was 9 and dose was unaltered. So after 15 days of admission, she was discharged with in stable condition with serum creatinine was 1.1. She was taking tacrolimus 2.5 milligram BD, tablet mycophenolate mofetil 500 milligram TDS, and tablet predni 17.5 milligram BD on follow-up with tablet valganciclovir 450 milligram BD. Now she came for follow-up. She was asymptomatic.
So summarize it, Dr. Advait just joined. So,
Yes, sir. So, sir, she's 26-year-old female from Bangladesh, staff nurse by occupation, Muslim by religion. So she was post-transplant. She's asymptomatic during follow-up. Actually, she was first symptomatic in August 2021. She was 4-month ANC. That time she had history of pervaginal leak and history of fever with chills. That time she didn't have any issue of decrease in output, no issue of cough, common cold, no issue of yellowish discoloration of eyes, urine, no issue of pain in abdomen, no issue of nausea, vomiting. This time she was admitted at private hospital at Dhaka. That time she was told that she had
don't restart, just summarize.
that time she had history of hypotension. And she was told that she had increased leukocyte count, so she was started on this antibiotics. And actually subsequently she deteriorated in the form of she had anasarca and uremic symptoms and anuria also. So she was told that she had renal dysfunction and serum creatinine was increased to 3.5 and HB was low. So she was started on dialysis through left femoral double lumen catheter initially. She received daily dialysis for 3 days and after that it was started on alternate day. And she received blood transfusion on dialysis also that time. So after starting dialysis, she had issue of fever with chills after 1 week on dialysis. So her actually she knows that her blood culture was sent. It was showing growth. So she and which was sensitive to tigecycline. She was started on antibiotic that time. So actually for 20 days she didn't have any output. After that she was having output. Initially it was 30 ml, which was increased to nearly 1 liter after 1.5 months. That femoral catheter was removed and she was actually right.
Summarize. You're telling the entire story.
She had septic actually abortion that time.
Yes. She underwent a transplant.
Actually,
incompatible mother and brother, so she underwent cousin.
Actually, she was dialysis dependent.
Though her urine output improved, she continued to be dialysis dependent.
The urine output was improved, but her creatinine was stable at 7. So she was continued on dialysis. Biopsy was not done because she was dialysis dependent. Her workup for renal transplant was done. Her actually mother and brother was ABO incompatible, so it was not done. Her cousin brother was willing to donate, and he has same blood group, so his workup was started. But prior to transplant, she was HCV positive, so treatment was taken for 3 months nearly. And after that, 2 times HCV RNA was done. Both time it was not detected.
This is the donor. Donor was HCV positive?
No, recipient.
I thought the donor was.
So prior to transplant, she was given pre-medications, immunosuppression, and injection ATG was given on the day of transplant. And she received 3 doses of ATG as told by her. And post-transplant on day 3 she had issue of venous leakage which was associated with hypotension and giddiness and fall in HB. So she was actually explored and leakage was sutured at that time.
So if you have looked at this patient now, so what do you think happened to her? What's the cause of a kidney?
Actually, she has septic abortion that time, and septic abortion with acute cortical necrosis might be there that time.
So
and
you
that
think one possibility is that she has had, what kind of cortical necrosis would it be? If
it is
cortical necrosis?
it is diffuse cortical necrosis mostly.
If it is diffuse
Diffuse, no, actually
then
patchy,
she
sorry,
recovers,
patchy.
Then she recovers also and then has good, reasonable urine output.
3 to 4 creatinine.
So with 3 to 4 creatinine has an intervening period
It is
of
patchy, sir, actually.
non-dialysis.
It is patchy mostly.
So would be a patchy cortical necrosis. So one possibility is that this is a patchy cortical
Yes, sir.
necrosis. Any other possibility?
It could be, sir, thrombotic microangiopathy.
Thrombotic microangiopathy.
What are the points favor? What is the points against?
She had low platelet count that time.
Correct. Then?
Low hemoglobin also.
Okay.
But other workup actually.
Not the workup. In the history wise, what are the points against?
Low platelet count and low hemoglobin.
Clinically, what?
You said hypotension.
Hypotension.
Hypotension goes against the TMA.
Renal dysfunction
And
also.
raised WBC counts. So fever can happen with hemolysis also.
Why did you say septic abortion? Was there any-
Because she told that she had high TLC count that time, and she was requiring inotropic support also, and low platelet count was also there.
The hypotension may have been because she
of
had some
bleeding.
bleeding also. No? She had some bleeding also at that point.
Sir, but she had fever also that
She
time.
had fever also. Yeah, so some infection during that period of time obviously was there. She was on inotropes and all that.
So how can you differentiate that it is a septic abortion or a routine abortion?
Sir,
He has
actually,
aborted.
routine abortion, actually patient didn't present with fever, hypotension.
She has aborted. She has
Ah.
product of conception. Looking at it, whether you can say it is a routine or it is a septic.
So symptom wise actually, we can differentiate.
The symptoms, she had fever, she had hypotension, everything. Even the product also you can look at it. Whether it is dead, macerated, then it will be a septic abortion. If it is alive, then it is less likely to be.
The products of consumption could
Consumption.
also be cultured and all
Cultured
that. So
and-
you could do a culture around it, or even the products of consumption could be sent for cultures in there.
Why there is an increased chance of cortical necrosis in pregnancy?
Because of ischemia, renal ischemia, that and
What happens to the blood volume and the blood flow to the kidney in pregnancy?
so blood flow to the kidney will be decreased.
Would be
Normal
pregnancy.
Normal pregnancy.
It is increase in normal pregnancy.
By how much?
Nearly 30 to 50%.
And what happens to GFR?
GFR is also increased.
GFR. And the blood volume is?
Blood volume is also increased.
Increased. So what happens to the angiotensin in patients with pregnancy?
Response is normal or blunted? What happens?
Response is blunted actually.
Fine.
Response is blunted.
Angiotensin levels are high or low?
Levels are not.
So you have a pre-eclampsia patient and you have a normal pregnancy. So angiotensin will be higher in which way? Whatever. I don't know. Yeah, normal pregnancy is higher and it is because there is vasodilatation, so prostaglandins and vasodilatory prostaglandins and prostacyclin, all of these are much higher, which antagonize that high levels of angiotensin. And that's the reason if you give angiotensin to these patients, they are not responsive to the vasoconstrictor effect of vasopressin this angiotensin is very low in these patients, so they don't vasoconstrict. In comparison, patients with preeclampsia, there is less vasodilatation and the angiotensin levels are not very high, but they Despite that, there is high vasoconstriction in these patients, and that's basically because the vasodilatory prostaglandins and others are not. So this is.
But why are they prone to develop cortical necrosis? Patients who are pregnant, in spite of having a high blood flow to the kidney.
Yesterday, Gopal's patient, sir, also
Yeah,
told
so
the
the Schwarzman
Schwarzman.
Schwarzman phenomenon. Anyone talks about? Can you explain? You know
Actually,
Schwarzman
I know,
phenomenon?
but I didn't recollect it.
You can't recollect it. Anyone who can recollect?
Hypersensitivity reaction to the endotoxin, and that is causing the thrombogenic growth.
So
and
it's
that
a
is
re-exposure to the endotoxin, the response is very aggravated.
What happens to nitric oxide levels?
Nitric oxide level will be increased.
It will be actually high.
High.
So what happens, see, that is why you are very concerned about any volume loss in pregnancy. Even 500 ml of blood loss or retroplacental clots, somebody having an abruptio, they are more prone to develop AKI because the nitric oxide levels are very high and there is no further defense. Right? What is the precursor of nitric oxide?
Nitric oxide.
Arginine.
L-arginine.
The L-arginine is being used up by the growing fetus. So the precursor is also low, the byproduct is already very high. So all the defenses are lost. So that is why, there is maximum blood transfusion happening in the obstetric department because they want to rush blood. They do not want to. Any volume loss, any small volume loss is considered very significant. And you want to protect patients against cortical necrosis. If you find anybody with an aseptic abortion, an obstetric kidney injury, acute kidney injury, especially in abruptio, they are more prone to develop cortical necrosis. How will you diagnose cortical necrosis?
On the basis of biopsy mostly, and on CT also, there is retrograde flow.
Retrograde?
That is one reversal of flow.
What about the calcification?
Calcification also.
CT. In this patient, biopsy was not done
Not
because
done.
it was thought that the kidneys are small.
Small.
in size. So, could you have confirmed the diagnosis of cortical necrosis by any other method?
CT only, sir.
Yeah, in ultrasonography, a good ultrasonologist might pick up calcification. And then CT scan, a plain CT scan would be a very good test to look for calcification. Usually occurs in about 6 weeks to 2 months periods of time, 4 to 6 weeks, 8 weeks. You will find calcium, rim of calcium around the cortex. So in this patient that wasn't done. I think
No,
she doesn't,
not done.
she doesn't remember that. Okay. He received.
Suppose you are transplanting this patient, what other investigations would you like to do?
I would like to do autoimmune workup, like APLA profile and ANA. Then genetic workup for atypical HUS also I would like to do.
And she received 2 units of blood transfusions.
Sensitized.
Sensitized.
Yeah.
The immunological workup would be
Pre-transplant,
You
then
said-
panel
You
reactive
said
antibodies.
CDC, you said.
Haan.
Anything else you want?
Panel
to do?
reactive antibodies
More
should
than
be
that.
done because DSA.
What panel reactive antibody, what information it will give?
Regarding any sensitivity,
It will give you sensitivity, but towards the donor is already there.
whether
So any enhanced cross match or any more sensitive cross match?
single bed, single bed.
So you will do a flow cytometric
Flow
cross
cytometric.
matching also in this patient, because that's more
Yes.
sensitive. And you will also
Single
might
antigen bead assay.
also look at if flow cytometric cross match is positive, then probably a
Single antigen bead assay.
But some centers probably might do single antigen bead also in this kind of a setting, because this is a patient who has received blood transfusions. And all. Okay. So you would do this.
So So this is, you said this patient had a venous leak.
Yes, sir, at the anastomotic
Were
site.
you very particular? Did she tell you? How did
Actually,
you
she
She's a nurse.
told that she
She's a
had,
nurse.
she was told that that time she had venous leak at anastomotic site.
What are the normal anastomosis that happen? To put in a transplant kidney, what are the anastomosis?
Sir, renal vein of recipient will be connected with the external iliac vein, and renal artery with internal iliac
How
artery.
side to side, end to side?
Side, end to side.
Right? Graft artery?
Internal iliac artery mostly.
Yeah, different teams do different things.
Internal iliac artery, then
Renal artery with internal iliac artery.
Is it end to end or end to side?
End to side.
End to?
end to end.
End to end.
Then
What about external iliac? What is the problem with an external iliac anastomosis? What are you worried about?
No. Renal artery stenosis near risk.
Oh, more serious than a serious. What? Dissection, anything more
Thrombosis.
Yeah, if there is a thrombus in the artery, it's going to extend down into the external iliac and may compromise the blood flow to the limb. So that's the major concern. In your center, how is the ureter to blood anastomosis? You just anastomose straight away, or some anti-reflux measures are employed?
So, yeah.
Yeah, these are different techniques. Again, surgical teams would, different teams would use different techniques depending on their experience.
So here you said she received thymoglobulin.
Yes, sir.
Could she have been given something else also as an induction
Because,
agent?
sir, her donor is also actually her cousin brother from maternal side. So it is better to give ATG because she also received blood transfusion.
What are the reduction therapies which are available?
This is lymphocyte depleting agent and lymphocyte non-depleting agent. Lymphocyte
What's
depleting
the
agent.
non-depleting agent?
Basiliximab.
Basiliximab. So, what's the evidence that thymoglobulin is better than basiliximab?
Sir, there are certain trials, actually I didn't recollect the name, but in that trial they said that ATG is better in high risk patient than basiliximab.
Yes, in high-risk patients, there is good evidence to show that thymoglobulin would be the. So, would this patient be classified as a high-risk patient?
She is
or
high risk. She is high risk because she received blood transfusion.
So, what defines risk?
History of blood transfusion, history of pregnancies, history of previous transplant, age also.
HLA matching, mismatching.
Actually mismatch also.
Sensitization, history of sensitization in this pregnancy as well as
blood transfusions she had.
Blood transfusions.
How do you give ATG?
Actually, it is dose is 1.5 milligram per kg. It is given. It is given IV. Actually, it is given with micro droplet, 11 drops per minute over 6 hours. Pre-medications also required, like hydrocort and antihistaminic, and paracetamol should be given to prevent infusion reaction. Methylprednisolone, methylprednisolone was given 7 milligram per kg prior to starting ATG.
If you don't give methylprednisolone, what will happen?
So risk of anaphylactic reaction.
Cytokine reaction because of the lysis of
Cytokine.
the lymphocyte. So how do you detect the cytokine storm?
If patient after starting ATG, if patient is having tachycardia, hypotension, then
chills, fever, difficulty. What should be the dry weight before giving an ATG? weight of the patient has to be considered before giving an ATG.
It should be, don't know, sir.
Have you given it yourself? Or
Yes,
no?
sir, I have given.
You given it?
Ah.
Okay. You gone to the operation theatre to see the transplant also, or you
Yeah.
haven't seen the transplant?
No, I have seen.
You've seen the transplant. Okay, that's good. Yeah, please.
I start with two things which have been discussed and one thing which has not been discussed. Can you hear me or?
Yeah.
Yes, sir.
Firstly, at our time, there's no CT scan. We used to do straight X-ray to see cortical calcification. And there are various descriptions, tram, track, calcification or something like that.
Yeah.
So why it is called tram, track, calcification? Do you know why cortical calcification is said to be tram, track, calcification?
No, sir.
Anybody? This is a parallel sort of calcification. Why it is parallel calcification? What is the cortical blood supply?
Arcuate arteries.
Arcuate artery to the cortical radius artery.
And also
From the
yes.
capsule of
There are capsular supply as well as from inside. That's the reason when you have two linear type of calcifications, in between there will not be any calcification. That's the reason the cortex has dual blood supply. Second, as sir was asking you about methylprednisolone, the superiority of methylprednisolone over the other corticosteroids. Do you know of why methylprednisolone is superior to other steroids? Anyone? Actually, the steroid receptors, they are internal to the cell membrane. It is said that when methylprednisolone attaches with the receptors outside, then these receptors, the steroid receptors, they get exteriorized. So the number of receptors exposed to corticosteroids increases. That happens only with methylprednisolone, the only form of steroid other than any other form of steroid. So the number of receptor occupancy with steroid increases with methylprednisolone compared to other steroids. That's the reason why methylprednisolone has a very sharp, short, rapid action. These are whatever has been discussed. I have only one small thing. I'm very fond of asking this question. Suppose a patient got transplanted and you are visiting the patient the first post-operative day. What are the things, what are the points that you will see, note, and why?
Mostly his early urine output I will check. Then
No, just one. So you are happy. Suppose the sister says the urine output was 6 liters. You are happy?
in how many duration it was, I will check.
So
How much?
urine output.
Serial urine
Yes,
No,
serial urine
hourly.
output. Hourly urine output or the serial urine output. Because the patient might have passed 6 liters at night and since morning the urine output has dropped. So that is one. Second,
Then her blood pressure, patient's blood pressure, pulse rate, that should be.
just one after the other.
Blood pressure.
Suppose the blood pressure is 120 over 80. So you are happy?
Not a.
So you tell me, what exactly you want to see, the blood pressure or the serial blood pressure as you have said?
Serial blood pressure.
So once again, you have to be very specific. It is not the snapshot blood pressure. It is serial blood pressure. If the blood pressure, suppose at night the blood pressure was 170 over 100, in the morning you find the blood pressure is dropped. Or to the contrary. To the contrary, the blood pressure was stable. In the morning there has been a surge of blood pressure. So serial blood pressure or hourly blood pressure. Next.
Early pulse monitoring also.
Pulse. Okay. So once again, whether there is a recent onset tachycardia. For
Then early abdominal girth also will check.
abdominal gut, in that case you have to measure the abdominal gut before and after transplantation.
Ha.
We usually don't measure abdominal gut.
So
But
we'll
what are the
measure.
things that we usually see?
Drain,
Yes.
drain output.
Well, not only output, even the
Drain
colors
color
of the
also.
urine, that's very important. So we look at it, all of us, whoever does the transplant, we look at the pipe, how the
Yeah.
urine looks. Next.
Then
To check weight.
central venous pressure, actually we usually
Venous pressure in the
yes, actually we measure, sir, post transplant hourly for volume status.
No, I don't. Okay,
The
then
weight of
maybe
the
your
patient.
practice, maybe
Weight
your
of-
practice.
weight of the
weight
patient.
Yes. Weight of the patient. Next.
Peripheral
Then blood.
pulsations. Peripheral pulsations. Why?
To see this thrombosis.
Next.
And blood investigations will.
Not investigation. I'm
Examination.
asking about the clinical assessment, the bedside clinical assessment. What are you going to do?
Thigh girth, actually.
Yes.
Thigh girth. Thigh girth.
Thigh gut. Okay. Next.
Then
Chest examination.
Clinical examination.
chest X-ray.
Bedside clinical assessment. Examination. Simple things you can collect from the sisters.
Respiratory examination to look for any added sounds.
Additions.
Added sounds. Respiratory examination.
Respiratory. Okay. Whether the patient has developed any fluid overload or not.
हाँ.
Okay. Next.
Then bowel sounds, actually.
For that, JVP also.
हाँ.
Bowel sounds. Okay.
Then clinically,
Any fever
yes, sir.
or the reverse.
Hypothermia.
Hypothermia.
Hypothermia also.
Why hypothermia?
Yes. He's asking why hypothermia.
How much fluid you give on the first day?
Actually, we will give fluid according to CVP monitoring.
Right.
Actually, nearly 9.
Output is hourly 700, you said.
हाँ.
So how much is the total output?
Sir, it could be nearly 8 to 9 liter fluid.
So then what happens to the
Actually, cold saline, if given, then it will cause shivering, and
what is the effect of hypothermia on the kidney?
it will cause vasoconstriction of vessels, that will cause renal leakage.
And the graft site, whether there is any recent swelling, tenderness. Tenderness is very difficult to elicit in the first post-operative because the area is tender. But suppose the graft site has swollen.
Leakage.
So that
45 minutes over.
Pardon?
45 minutes over.
Over.
40 minutes
Okay,
over.
fine. Then it's okay. So we are interested in these. Your clinical acumen, your assessment, the bedside assessment, the next day what are you going to do? These are the things that we are interested in. Understand?
I think in your presentation, I would suggest that there is no point in saying that a chest X-ray is planned and then a chest X-ray was done. So it's usually give it as a story, as Dr. Gopal Kishan was saying yesterday, and collect all the no's together and say one no, this, no, this, no, this, no, this, there is no point in doing this. So the presentation can be. Then when you summarize, then make a good summary, which is not description in detail about the same thing that you did again and again. So in summary, you should be very precise. Even otherwise, be precise, be quick in giving. You have a long history, but you should be able to make it concise. So it's very important to delete something which is not necessary. You can say that she has had recurrent catheter in CLB infections and all those. So you can
Directly you can
directly
say
you can
catheter
say that.
related
Yeah,
infections.
catheter related infections. So there is no point in giving each
Right.
description of each and every in very great
Right,
detail.
blood culture
and
was
all.
taken, it was positive, sensitive to she had CRBSI, sensitive to tigecycline, and she
which
treated accordingly.
was treated accordingly. So make your presentations very, very concise, because you take long time to present, then the number of questions which are going to be asked is going to be small, because you will finish your case before that. So that's very, very important for all of you. Learn to present your cases in such manner that it doesn't take away the attention of the examiners away from the case.
You are a national board candidate or?
DM candidate.
DM. So there is a variation here.
Yeah.
The DM, there is a long case and a short case. So in the DM exam, you have a little more time to present.
Yeah.
While in national board, you have only half an hour because you have to present 4 cases, 50 marks each. So that is where this summary is very, very important, as sir mentioned to you. So if you are going to take more than 8 minutes to present your case, then there is no time for discussion. Then the examiner feels that we have not discussed this case, and then where a good discussion you would have offered, but then if you take a lot of time to present, then you lose time and don't allow the examiner to assess you well. Right? So that is why we are insisting that summarize it well. And
even in history also, you are a super consultant. Patient told she had WBC comes.
Sir, she was.
Suddenly, you can say that she had a fever, and she was diagnosed as this. Okay, that will concise. Otherwise, you are unnecessarily prolonging your time, and you are having less time for discussion.
I think that's what I would say probably. Just
present more
present,
often.
Yes, present more often. I think that would be important. What year are you in?
I'm third year, sir.
You're the third year.
The exam.
Exam. Okay.
Okay, thank you.
Thank you.
Next, I'll be a short case presentation by Dr. Raj.
Good morning, sir. I'm Rajdev from KMC Manipal. I'll be presenting Mr. Manoharan M, a 68-year-old male residing in Egmore, Chennai, postgraduate in MA, ex-marketing job in a food product company, came for follow-up in the hospital.
Just one thing. Whatever you have said, ex-marketing man, he hails from this and that, do you think these have any bearing on the diagnosis? If they don't, it's not necessary. As they're saying, unnecessary statements you try to avoid. Suppose his age, sex or something has some bearing on the diagnosis, go ahead. But whether he is a marketing man or he hails from that place or that, useless. Don't go ahead with that. Delete those.
Unless there is a significance to the
Yes. If it has a bearing on the diagnosis, fine.
Suppose the endemic nephropathy and you say this, then it is important.
Yeah.
You think of an anti-GBM disease and he's on a particular occupation, then that becomes important.
In your management, it may be important to know what he is doing and all that in the long run. But presentation, he may not be as important. So what I'm saying, in practice, when you practice, then it may be important to know what is he doing and all. Yes, good.
Patient is a known case of chronic kidney disease on peritoneal dialysis. I'd like to go back 30 years back when the patient was diagnosed with hypertension on a routine follow-up and was prescribed on 2 classes of antihypertensive, and that was tablet amlodipine and tablet atenolol. Following that, he continued his medication and was on regular follow-up. 10 years back, he noticed lower limb swelling and had gone to a local physician and had undergone investigations and was told that his creatinine at that point of time was 4 mg per deciliter, and ultrasound was done, which was told that it was small. There was history of NSAID abuse in the form that he was taking diclofenac for the last 5 years, and no history of fever, rash, no history of decreased urine output, hematuria, frothy urine, nocturia, polyuria, or recurrent urinary tract infection, no urgency or precipitancy, no history of epistaxis, hemoptysis, or dryness of the eye, double vision, no history of suggestive of graveluria. He was not offered any biopsy at that point of time, and he was told to continue with his antihypertensive medication and follow a conservative line of management. Over the years, he continued his routine follow-up and was told that his serum creatinine was progressing, to the point that in January 2018, he had developed nausea, vomiting, nausea and decrease in appetite, and he was admitted to the hospital, and he told that his serum creatinine was 8 mg per deciliter and had been offered to undergo hemodialysis. He underwent a hemodialysis through a right IJV. The first 2 sessions were a short session, and subsequently a left brachiocephalic fistula was constructed and cannulated 2 months later. He continued dialysis through the left brachiocephalic fistula for the next 3 years. Initially twice weekly dialysis, which was subsequently increased to a thrice weekly in a single center, with an intradialytic weight gain of 3 to 4 liters per session. At that point of time, his residual urine output was 800 ml, and he was on a regular hematinic medications. And also he had been vaccinated for hepatitis B vaccination. In May of 2021, he had developed an absent thrill over the left brachiocephalic AV fistula, for which a temporary catheter had been inserted in the left IJV, and a right brachiocephalic fistula was constructed. During the 2 months later, during the cannulation of the right brachiocephalic fistula, there was a massive swelling, and subsequently the fistula was abandoned, and he was told to undergo peritoneal dialysis, and the peritoneal dialysis catheter was inserted in June of 2021. At that point of time, his residual urine output was 400 to 500 ml per day. Initially, his PD catheter regimen was 2 bags of 2.5% dextrose for 4 hours each dwell, and it was increased to 2.5 bags 2.5% dextrose, 4 bags, 4 hours each dwell, and 7.5% icodextrin, 1 bag for a 12-hour dwell at night. He continued his PD catheter, he continued his peritoneal dialysis, and in June of 2022, he developed a cloudy peritoneal fluid effluent in the bag, and there was history, it was associated with pain in abdomen, but there was no history of fever, vomiting, or pain during drain or infusion. He does not remember any break in his technique at that point of time, but he has a animal at home, and the dog is there at home. He came to the hospital, and he was investigated for, and he was told to have a bacterial infection, for which an IV, he had to take IV antibiotics for 3 weeks. But due to non-resolution of the cloudy effluent, he was advised to remove the catheter, and subsequently, simultaneously, new peritoneal dialysis catheter was inserted. In March of 2023, patient developed pain in the exit site, and which was associated with pus discharge. There was no history of fever, vomiting, or cloudy effluent in the peritoneal fluid. At that point of time, patient remembers that there was a faulty connection at the junction of the transverse set and the peritoneal dialysis connection, due to the change in vendor of the supplier in the peritoneal dialysis. He was treated with capsule clindamycin for 10 to 14 days, and it had improved. And currently, he had come for follow-up. He complains of mild lower limb swelling, otherwise no shortness of breath. There is improved quality of life, and he's performing his peritoneal dialysis by himself. His current regimen is 2.5% dextrose, 4 bags for 4 hours of each bag, with a nil residual urine output and a current dry weight of 77 kgs. He achieves a total of about 2 liters of ultrafiltration, and his drain time is 20 to 25 minutes with an infusion time of 15 to 20 minutes. Past history: he's a known hypertensive since 30 years and gout since 25 years. No history of diabetes, bronchial asthma, tuberculosis. No history of prior surgeries or blood transfusion. He has 7 siblings, and there is no history of diabetes, hypertension, or any kidney disease in the family. personal history, bowel,
Anything significant? Just mention the significance.
no,
Examination, this is a short case. You go ahead with the examination. Examination.
patient's conscious, cooperative, oriented to time.
Go ahead with the positive findings.
His BP is about, his BP right arm supine position was 100 by 60, and in standing it was 90 by 60. Otherwise, there was edema up to the knee up to the knee, and there was 2 surgical scars in both at the level of the elbow in both the upper limbs. And in per abdomen examination, it was soft, non-tender. There was scar mark in the periumbilical region of the previous catheter in the right side, and currently has a catheter in the left side periumbilical region, and there is no redness, discharge, crusting around the catheter.
So that's all in your examination. I'll initiate and then.
Yeah, please.
Firstly, regarding his basic disease, what do you consider as the basic disease?
I'd like to consider chronic glomerular sclerosis.
Chronic glomerular sclerosis. It's a syndromic diagnosis, chronic glomerular sclerosis.
C.
So, do you think there's anything like chronic glomerular sclerosis?
Chronic glomerular nephritis.
Chronic glomerular nephritis. It's not hypertensive nephrosclerosis.
Could be due to
no, I ask you, what about your impression, whether it is CGN or hypertensive nephrosclerosis? Though these are not syndromic diagnoses, but regarding his cause of chronic kidney disease, whether it is hypertension or CGN?
Probably due to hypertensive nephrosclerosis.
You just said it is chronic glomerular nephritis. Nothing. What's the logic? Why you say it is hypertensive nephrosclerosis?
He presented with lower limb swelling and.
So when somebody presents with lower limb swelling, the likely diagnosis is hypertensive nephrosclerosis or it's a glomerular disease, CGN?
The amlodipine could also be cause edema.
You say, suppose we consider it is hypertensive nephrosclerosis. What are the other telltale evidences of long-term hypertension he has? What are the things that you have searched for in your examination?
Look for apex beat will be displayed.
So you have not mentioned about whether he has hypertensive heart disease, whether the apex is down and now. Did you mention?
I'd examined for.
No, I asked you about your examination findings.
Positive findings.
The positive findings, negative findings. Any changes in the retina? You have not mentioned anything, not a single word about retina, whether there is hypertensive changes in the retina. You didn't mention. Did you? So what is your impression? Suppose you are considering hypertension as the cause of nephrosclerosis, and you have not examined the position of the apex plate, whether there are hypertensive changes, the telltale evidences of long-standing hypertension in the heart or in the retina, and you are happy with the diagnosis of hypertensive nephrosclerosis because he is hypertensive.
And you
The edema will be there. I mean, in any sort of chronic kidney disease, at the later stage you get edema. But a person who has a history of 30 years of hypertension, you say 30 or 32 years of hypertension. So you are not bothered to see whether the patient has retinopathy, hypertensive retinopathy. Second is, you said the patient was on atenolol.
Yes.
So, of the beta blockers, do you think a patient who has renal dysfunction, atenolol is a good drug? Suppose you are a nephrologist, patient has come to you with high blood pressure and renal dysfunction. What will be, suppose you are supposed to give, say, has tachycardia, you want to give a beta blocker. So what will be your choice of beta blocker?
Carvedilol or metal.
Somebody is prompting, they will not be there in the So regarding beta blocker, only carvedilol, there is no other choice.
Metoprolol.
Pardon?
Metoprolol.
Metoprolol plus minus and anything else?
Bisoprolol.
They said bisoprolol. Are you happy with bisoprolol? What's the problem with bisoprolol and atenolol?
Not.
Nothing called cardioselectivity. Both of them are notorious to develop bradycardia. Which beta blockers in presence of renal function can cause hyperkalemia? Don't prompt, let him answer and then I'll ask you.
Metoprolol.
Metoprolol causes hyperkalemia. Which beta blockers cause hyperkalemia? Propranolol, yes, and labetalol. Labetalol and propranolol, both of these can cause hyperkalemia. This is very important. I think you should read one article by George Barkris. It was published, I think, 6-7 years ago. Beta blockers in presence of chronic kidney disease and renal dysfunction. You can search it from your instrument. It's a very good article. What will be the choice of beta blocker? Okay, so atenolol is not a very good drug. Particularly, they are associated with a lot of atenolol. The good thing is that it is very cheap. Otherwise, there are reports of brady. So, I mean, they will ask the other questions also regarding CAPD and all, what happened, repeated failure of chronic peritoneal dialysis and everything. I just want to ask you about, in this patient, at this juncture, what will be your advice? Continue with CAPD?
He can be continued on CAPD, and subsequently he can plan for a cadaveric.
You said 68 years of age. Yes. 68 years of age.
Yes.
Cadaveric transplant. What was the degree of control of blood pressure? You did not mention anywhere.
Yes.
What was the first time when it was detected? What was the blood pressure? And
that
other evidences are said you have not mentioned. And the degree of blood pressure control was not mentioned at all. Because that matters a lot for a nephrologist. Why? Why it matters?
Good control of hypertension will retard the progression.
So if it is 130, 80, 140, 90, 190 by 100, what is the rate of progression of kidney disease with each? Dr. Bektis has said it is a chart everybody sees. Why the ACE inhibitor was not added, ACE inhibitor ARB? Is there any contraindication was there?
At that point of time, no contraindication was.
It is the best drug to reduce or retard the progression of kidney disease.
Yes.
How do you decide an antihypertensive agent? If a patient comes to you, 3.5 creatinine, 4 creatinine, how do you decide which antihypertensive to use?
If he's not got any acute kidney injury event or anything, he could be added on ACE.
What do you see first?
Proteinuria.
Proteinuria. The proteinuria, if it is 800 milligram, another patient has 2 grams. EGFR, okay, and
potassium.
The potassium is more than 4.8 or 5, and you have a higher chance of hyperkalemia, so better not to add. Or he is not coming for a regular follow-up, is not following, better not to add an ACE inhibitor ARB. And if you started an ACE inhibitor ARB, then what you do next? You have started the patient.
Tell him to monitor his creatinine.
When do you monitor?
1 week.
Okay. If the potassium which was 4.5 became 5, what you will do? How much is the GFR reduction you expect?
Less than 30%.
If it is 30% reduction, 3.5 creatinine became 4.5, then what you will do?
We'll look for any other causes for acute kidney injury.
What?
Or,
First is hydration status, use of diuretic.
hypovolemia or
Right.
and use of any NSAID contrast or
And then obstruction.
rule out obstruction, and then only to consider for stopping ACE or.
Okay. So what should be the target of blood pressure in CKD?
Less than means systolic of 130 and diastolic of 80.
Because the latest guideline, KDIGO guidelines suggest.
120 in diabetics 130 and in non-diabetics 120.
Irrespective of the hypertension, it's the guidelines suggest now 120/80, and that's based on what?
Sprint trial.
On the sprint trial. And all. Yes, and you should also look at your patient. So it's also said that if they are able to tolerate that. So that's very, very important statement.
With comorbidity.
So, with comorbidity and all, you may
Vascular
not
disease.
want an elderly patient who has frailty also and might fall, develop hypotension, then you might cause an acute deterioration in his overall health, rather trying to look at a long-term outcome in that. But if you have a younger patient, a 20-year-old young person or a 35, 40-year-old person, then that is the kind of a person where 120/80 would be the kind of target that you should be able to achieve, and that's what one should do. One?
They have not given the diastolic target, and they have just said the systolic more than
Less than 120. 120, yeah. Less than 120.
It is entirely from sprint.
Yeah, yes, entirely.
So what is the standardized blood pressure?
Automated office blood pressure man, in which 3 readings are taken.
Right.
Via standardized machine.
Okay.
The patient should be calm, composed, sitting, then no campaign, then bladder should be empty.
And it,
No talking while.
No talking while.
He should be in a separate room, resting for a.
resting,
Which
placing
is
his heart
which-
on the table
Yeah.
and back support and leg support.
Not an easy thing to do in Indian outpatient clinics, but that's
First
the
place
way.
you can- yeah.
So if that's what's not likely to happen in our clinic, so what would you tell your patients to do then? What would be the any
Home BP
Home
monitoring.
BP monitoring is something that you should advise your patients to monitor, and maybe bring a chart next time they come to the clinic. That's what would be very, very useful, because that tells about the control of blood pressure at home, and that may be. So you need to also ask them to get their machines off and on in the clinic so that you can calibrate these machines.
Most
also.
of the
That's
machines
also,
are not recognized by the guidelines.
Yeah, that's the problem. But you have 1 or 2 good machines now available in the market. The ones which were used in the sprint trial also are available now. MicroLife instruments are available now. So you
What are the problems of home blood pressure monitoring
Yeah.
in CKD patients? In CKD patient, what is the problem with home blood pressure monitoring? What are the characteristic features of hypertension in a CKD patient? What are the typical characteristic features?
There will be no nocturnal dipping at.
So
lost.
when you go by this HMBG, then the problem is HMBP. Then the problem is this nocturnal change, the night riser or absence of nocturnal dipping, they may be missed out. That is the problem. So that's the reason why it is recommended nowadays that at least once you will have an AVPM. Otherwise, you will miss this rise in nocturnal blood pressure, which is very common in chronic kidney disease. Understand? What are the other features of hypertension in CKD? Early morning surge, okay. Anything else?
What happens to the salt sensitivity?
Decrease in the
resistance hypertension.
Decrease in salts.
Anything else? What is called masked hypertension? What is masked?
In the clinic, the BP will be normal, and at home the BP will.
So this masked hypertension, is it more common in CKD patients?
What is the outcome? White coat hypertension, one patient, another is masked hypertension.
White coat is in the clinic, the BP is
okay. If the patient has come to your clinic, his blood pressure is 125/75, but you see his ECG, it is showing LVH. Then what you suspect?
masked.
Why?
No.
He said, okay, please.
Go ahead.
Please.
Okay. So this masked hypertension, do you know what is the classification of masked hypertension? Anyone? There are basically three types. One is called masked effect. Masked effect is the blood pressure is higher at home compared to the clinic blood pressure, but it has not reached the definition of hypertension. It's called masked effect. The second stage is masked hypertension, but which is controlled with medications. And third is masked uncontrolled hypertension. So basically there are three types of masked hypertension, or masked, this entire group. One is masked effect, second is masked hypertension, third is masked resistant hypertension. Understand? So when you know, you should know in depth that this is the entire spectrum. And also there is another classification which states that there may be masked daytime hypertension, the other groups masked nighttime hypertension. So this is the classification of masked hypertension. What is the association between masked hypertension and end organ effect?
Increased.
Or they may present with the endocrine.
Basically three. One is left ventricular hypertrophy, second is increased proteinuria, third is reduced GFR. Basically these three. There are other also, there is the vascular impedance and all, but these are the three that was in the ASK study. It was shown that these are the three associations with masked hypertension. So, because in this patient there is another issue, that is analgesics.
5 years.
Analgesics. So do you think this can be a case of an analgesic nephropathy?
I had considered that as my second.
You have not mentioned, as of now you didn't mention anything about masked hypertension as analgesic nephropathy as one of the causes of, when I asked you regarding this, what is the basic disease, you didn't mention anything about analgesic. In the history of mention, but when you asked what is the basic disease, you said chronic glomerulonephritis, then hypertensive, but what about analgesics?
He had a consumption of analgesics for 5 years.
That I know, that he had a 30-year history of analgesic consumption. But is it a case of analgesic nephropathy? If yes, why? If it is not, why not?
Could be a possibility of analgesic.
Could be. Science, it is nothing like could be. What it is. What is your answer and what is the logic behind? What are the types of analgesic nephropathy? Do you know how analgesic nephropathy is being classified?
Causes papillary necrosis and medullary hypoxia and.
No, there is mechanism. I am not asking about mechanism. How do you classify analgesic induced renal damage? Analgesic nephropathy. It's a classification of analgesic nephropathy. Do you know it? If you don't know, they said I don't know.
I don't.
Then they will allow you to go away without it. The thing is, you have to read analgesic nephropathy, but it's so rampant nowadays. Mechanism we are not interested. What are the types of analgesic nephropathy, and the management of analgesic nephropathy also differs according to the type of analgesic nephropathy. Even the various analgesics, they affect the kidneys differently. So you should know of what is analgesic nephropathy. You said this patient's present blood pressure is 100/80?
Yes.
Why?
Could two possibilities. One is maybe a cardiac.
Time is up, na? Sorry.
Maybe a cardiac event or.
Cardiac event. Where is the history of cardiac event?
There was no chest pain anytime.
Don't bring some new diagnosis. Whatever you say, on that basis you tell us what is the likely possibility with the blood pressure. You said your diagnosis is hypertensive nephrostenosis without seeing the heart, without seeing the eyes. Now you say that it could be a cardiac event. So you go on bringing new diagnosis. It's not done. Pardon?
Because of anephric kidney.
So anephric kidney, anephric state. So in anephric state the blood pressure drops.
He has a CKD, he has two kidneys.
He is anephric anyway. Sometimes you are right. Non-functioning, I mean, even if the kidneys are non-functioning, there are afferent impulses and they may cause hypertension, and this may require either radiofrequency ablation, RFA, or it may require bilateral nephrectomy. I agree that is a distant possibility. It may happen because of the afferent impulses to the brain. It is a possibility. But in this case, the patient came with infections, COPD, peritonitis and all. Those are the likely diagnoses instead of bringing something far-fetched. That shows that possibly the infection part has not been addressed properly as of now. So it's still, that's the reason I was asking. Whether he had 1 or 2 episodes of peritonitis, and once again now his blood pressure is low, maybe a 3rd or 4th episode of peritonitis, what will be your choice of therapy? That's the reason I was asking.
And what is the nutrition, effect on nutrition? He has peripheral edema also, you said,
Yes,
with
yes.
blood pressure of 100/60 and even 90/60, he was having peripheral edema.
His fluid intake was on the higher side as well.
Higher side I agree, but even with CAPD, what are the antihypertensives? One. Second is 100/60 is lower and 90/60. So these are the patients in a 68-year-old. They are more prone to have fragility and fractures if they fall down. So that is the reason it needs to be addressed why he has postural hypotension. It's only 10 millimeter, but with edema he has blood pressure in the lower. Whether it's the infection which is causing, or is there any nutritional problems, heart problems, or the peripheral neuropathy, and he is getting significant postural hypotension. Everything needs to be addressed in this patient.
Okay, sorry, we are late. Next case.
There's a short case presentation by Dr. Sairaj.
Good morning, sir.
Please.
I'm Saili Devi from Bombay Hospital, Mumbai. I'm a 3rd year DM resident. I'm presenting a short case of my patient Shabana, who is 27 years female, resident of Chennai, married since last 7 years, housewife and having child of 6 years old. She presented with chief complaints of swelling of the legs since last 2 weeks and frothing of the urine since last 1 week. There was no history of reduced urine output, fever, dysuria or hematuria at present, and there were no history suggestive of other autoimmune involvement in the form of oral ulcers. There was no hair loss, joint pains or rash. History dates back in September 2022 when she first time presented with when she first time presented with 2-3 month history of gradually progressive pedal edema followed by generalized anasarca. There was frothing of urine, difficulty in breathing and reduced urine output. So she presented to a local doctor where after doing some preliminary investigation, she was told to she is leaking proteins from her kidneys, and she was symptomatically treated with oral diuretics. She knows the name that furosemide was given, and she was told to follow salt and fluid restriction. And when she had increased weight gain, when her weight reduced to almost 15 kgs, then she underwent kidney biopsy, and on the basis of that kidney biopsy report, she was investigated for like 7-8 days more with some CT scans. Then scopy was also done. Then some blood investigations were done. Mammography was also done as told by her. And then she was started on injection rituximab, the name told by the patient. And 2 doses were given 14 days apart. There was no significant, there was no history of infections, there was no history of malignancy or history suggestive of dry eyes, dry mouth, or any significant drug history was not present. So, and she was sent home on regular monthly visits. But in February 20, it was given in October-November 2022. Now in February 23, on routine follow-up, they found to have a urine test which was positive, like there were 4+ proteins, and on further inquiry she told that while she was doing that protein testing at home, she always used to have 2+, 3+ of proteinuria, and but there was no edema as such, but she said that bubbling was there. So her on follow-ups, her diuretic dose was adjusted and she was started on enalapril tablet, and the dose was also modified. She also said that her creatinine started rising from February 2023 till May, like till now, like from 1.9 to almost 2.4. So she was given option of kidney rebiopsy, but she gave history that the doctor said that there is no, that option was deferred basically, and she was started on this, she was started on some injection for 3 days, and she was also informed about the one special injection which the doctors are planning to give with her consent, and she was also told that there are like problems of infertility and the future. Her consent was taken, and she is now planned to give that injection in the future, in near future. So in this admission, there was no history of fever, sore throat, loose motions or dysuria. There was no history of orthopnea, PND, no history of NSAIDs or alternative medicines used. There was no history of hematuria.
Reduced. One no history and then enumerate. Each time everyone is telling you the same thing. No history of this, no history of this, no history, no. No history, then
okay.
7, 8, 10, 12, whatever you...
Okay, sir. Sorry, sir. There was no history, no history of joint pains, oral ulcers, photosensitivity. She is a known hypothyroidism patient. She gives history of one spontaneous abortion after 2 months of her marriage, which was spontaneous, and she conceived after 5 months of 5 months after that abortion. She had a normal pregnancy, but she said that at 8 months of at 8 months of ANC, she pursued reduced fetal movements, for which she was taken to the hospital where her BP was found to have 170/100. She was given some medicines. At that time, she didn't give history of any frothing of urine, blurring of vision, headache, pain in abdomen. So after that, she underwent emergency LSCS. Baby was 1.2 kgs. And that baby required NICU stay for like 10-15 days, and then got discharged in a healthy condition. She was also discharged. So, and for hypothyroidism, she is taking a Thyronorm tablet. And on personal, and after that pregnancy event, that short rise of like BP rise, her BP normalized post delivery. She was not on any hypertensives, antihypertensives till now. This event happened in 2017, her pregnancy. Till 2022, September 22, she was fine, she was alright. And this swelling and everything happened since September. So on personal history was not significant, family history was also not significant. Examination, she's
positive.
Yeah. Her
and important negative finding. Just highlight.
Okay. Her BP was 120/70 mm of Hg in right upper limb. There was no postural drop. euvolemic at present. There was no edema. The sacral edema was also not there, and RS was clear, and her weight was 74 kgs at present with height of 158 centimeter. She was obese, like BMI was 29, and there was no lymphadenopathy, and yes, there was no bruit. Peripheral pulses were felt well. Pulse was 88 per minute regular.
So what's your diagnosis?
So sir, my diagnosis will, she is 27 years female, like adult onset nephrotic syndrome. Looking at the treatment history, mostly membranous nephropathy.
So you feel this is membranous nephropathy?
If the rituximab history would not have been given by the patient, then I would have considered MCD FSGS also in this case. But as she has specifically told that at initial presentation only she was given rituximab, I'll favor membranous as a first diagnosis. And now
any other reason to favor? In one point that you said that she told you that she's received rituximab, so you nephrotic syndrome, membranous nephropathy. Currently, that's investigation.
She was investigated for the secondary causes of membranous. And sorry, I forgot to tell one thing, that she also told that she has been started on acetrom tablet for the low protein levels. She is currently on acetrom.
Okay. So the other thing was that the investigations suggest that mammogram was done and all other things were done. So that this was. So can you make another, what kind of membranous nephropathy it would be? Can you think of what would be the
lupus?
No, I'm saying that what kind of etiology. Nowadays, membranous nephropathy has many antigens. So can you predict which antigen it would have been? At least you tell me that which one is unlikely.
No,
BLAR2 is unlikely. BLAR2 is considered to be positive in about 70 to 80% of people. So which is the antigen which is considered to be related to malignancy or NEL1? So it looks like, I don't know, but somebody had investigated her for malignancy, and therefore I would think that probably maybe NEL1 was the antigen which was detected on the biopsy. This is a prediction. So from one.
If BLAR2 comes positive, then the secondary part investigation should be done or not done?
It should
be done.
Yes,
because in the
it could be done depending on age-based evaluation, but by and large, yes. BLAR2 is less associated with malignancy in comparison to the NEL1 and the others.
In this case also, like in
membranous nephropathy, especially in the elderly population, you should do an age-related evaluation for malignancy.
She can also be PLA2 or like their NEL and PLA2 or both can be.
Two positivity is less likely.
No, either NEL or like.
So if there is a plateau positive, why they will go for so much of investigation?
Yeah, I would think that they wouldn't, because NEL is far more associated. And any other reason why NEL, other causes of NEL positivity?
Autoimmune conditions.
Yeah, indigenous drugs and all that. And only, I think only day before yesterday, Anil Kurian is published a larger series of 86 patients published in Kidney International. And again, NEL positivity in 86% people who had indigenous drug exposure. And she compared it to the non-drug exposure. So 2 or 3 studies have suggested that indigenous drugs associated with mercury as contamination in those drugs leads to membranous nephropathy, especially NEL.
One paper from interiors of Maharashtra also showed that
there are from mercury there are 2-3 papers.
AI is from Chennai only.
Yeah. Anil Abraham Kurian did it from Chennai, pathologist.
Suppose you hadn't had this treatment history, what are the possibilities? Because you are basing your diagnosis on the treatment history. Suppose this patient was not so well versed and just presented with a 27-year-old nephrotic syndrome, how would you approach?
My differences would be in that case like membranous nephropathy, as she was normotensive of the time.
27 years of age.
27 years.
MCD, minimal change disease, and FSGS.
FSGS first.
Lupus, IgA.
IgA
Like
nephropathy.
rarely, like lowest in the.
Hypertension. Then membranous.
Membranous.
So you should discuss it in the form that you would look at primary causes for nephrotic syndrome and then secondary causes for nephrotic syndrome. So out of the primary causes, you thought FSGS, MCD would be one, and membranous nephropathy would be another one out of the primary. Do you think membranoproliferative glomerulonephritis is likely or unlikely? What's the presentation with MPGN?
It's like more of a nephritic nephrotic.
Yeah, nephritic
So there will
nephrotic
be
syndrome. So you
hypertension.
will have some hypertension, some
Hematuria.
swelling and hematuria, microscopic hematuria and others. So that's not the renal dysfunction also at presentation. So that would not be unlikely. So secondary causes, you said lupus. Anything else?
Other autoimmune conditions, APLA, then inflammatory like Sjogren's, like rheumatoid arthritis, thyroid diseases, malignancy, like paraproteinemias.
She's on thyroid.
Okay.
Her creatinine is 1.9.
Her creatinine was in February 1.9, it got progressed to 2.4 now in May. Now they are planning to give her modified Ponticelli.
Is that common?
Exactly, yeah, exactly. I
Is
wanted
that-
to ask, is it
is
typical,
that
typical of membranous?
No.
Rise in creatinine.
So that is the reason we are a bit skeptic about the diagnosis of.
So what are the causes in which you can have membranous but maybe renal dysfunction in association? So what are the things that you will look for? This patient has, if you think this is membranous, but she has also renal dysfunction, which is unlikely to happen within the first year. Usually it takes how many years for renal dysfunction to happen? Yes, 5 to 10 years. Yeah, some 5 years or so.
Not only that, de novo, her creatinine 1.9 was at presentation.
Yeah, at present.
That is also very unlikely for
February.
September when she presented, her creat was normal.
Normal.
It was 0.8. Then she was given
She
rituximab.
received rituximab. In spite of that, the creatinine went up to 1.9.
Yes.
Yeah, the
Yes.
progress. So
Yes.
what are the causes of this rapid decline in kidney function in patients with membranous nephropathy?
Maybe acute, superimposed acute kidney injury
Okay.
or hypoproteinemia, low albumin,
AKI due to what?
AKI due to
Why should you 27-year-old lady develop?
Myeloma.
In the background of membranous.
Nephrotic syndrome.
The background of nephrotic syndrome, membranous, what are the possibilities of worsening of creatinine?
Yeah, you said AKI related to what? What are the causes of AKI?
pre-renal AKI.
Okay.
Right.
Because of
Pre-renal because of
Like
hypoalbuminemia.
effective circulatory
Okay.
volume is low.
Okay.
diuretics.
Diuretics.
Overzealous diuretic.
Okay.
Diuretics, right?
Renal vein
Renal vein
thrombosis.
thrombosis.
Yes.
How the renal vein thrombosis presents?
Severe abdominal pain
And
and hematuria.
hematuria.
Okay. What else?
But that history was not there.
No, that is
So we don't consider renal vein thrombosis in this patient.
Yeah.
So
No, she's
other
other
She's
causes.
already
You
on
were
acid.
telling, yeah, other causes.
Other causes.
She is already on acetrom for.
That doesn't prevent it.
Yeah.
If you are not having a right INR.
Yeah.
Can crescents form in membranous nephropathy?
Yes, sir. Crescentric
Unusual
transfer.
actually.
Unusual.
Can happen but very unusual. But a membranous nephropathy has a rapid deterioration of kidney function, what will it be called? Other than renal vein thrombosis and all that what we discussed.
Drug-related acute infestation and infection.
Yeah, that we discussed, diuretics.
And presenting.
Crescent due to what?
Sorry?
Crescent due to what?
Superimpose maybe
NTG.
NTGBM, which is what has been described more.
membranous having rapid deterioration of kidney function, if there are crescents, it is generally due to anti-GP. As such, in membranous crescents are a little less.
That may be one of the reasons why a second biopsy is being
Was
considered.
planned.
Being considered.
Yes.
Yes.
Why was rituximab, if you were the treating nephrologist, would you give rituximab?
Yes.
Yes.
Rituximab, that is
Why?
very interesting.
Yes, sir. She's 27 years female, reproductive age group. That is the first, and she at that time her creatinine was normal. It was not like rapidly deteriorating. She didn't present with AKF. Second thing, sir.
You said
there is-
20 kgs was lost and then she had. So
yes,
she.
sir. Yeah. 18 kgs. Her
Ah.
weight was 110 to 92.
So
was it.
she waited for so much of water accumulation and then it was diagnosed.
No, let alone the logistics.
Oh,
What is the evidence
The
that
evidence,
rituximab can be
like
used
in
for spinal
2017, one trial came that Remrudix, which compared rituximab and non-immuno, like supportive therapy versus supportive therapy. It showed that rituximab is superior. Again, in 2019, Mentor trial came, which also showed the superiority of rituximab.
It is
But there is
superiority or
No,
non-inferior?
it is at 12 months it is non-inferior, but at 24 months it is superior.
Superior because of what?
In terms of remissions, in terms, it caused delay, prolonged effect
Side effects.
and prolonged effect and less remissions.
Less relapse.
Less relapse.
Compared, see, you have to look at the comparators basically. So
cyclosporine.
various studies, so what is the standard of care which has been there before rituximab came? What was the standard of care for membranous nephropathy? Modified Ponticelli. For last 20 years at least, modified Ponticelli regimen has been considered to be the standard of care for treatment of membranous nephropathy. Once you decide to treat with immunosuppressive therapy, many patients are treated for 6 months, at least previously were treated for 6 months at least with ACE and ARBs and other supportive care to see whether there was either a spontaneous remission or a remission induced by these drugs. And how many percentage of people would go into remission with these kind of therapies?
30%.
Yeah, about 30% can have either a spontaneous remission
30% will reach ESRD and 30 will.
So once you decide to, then you have to look at comparative trials which are where rituximab has to be either as good as cyclophosphamide or better than it.
There is just now 21 RI cyclo trial came, which only has compared head to head. Other trials have not compared.
Yes, cyclophosphamide. So there were trials which compared rituximab with cyclosporin. So then, and modified Ponticelli. So these are the trials, and there is no trial which has shown rituximab to be superior to cyclophosphamide. Even the RI cyclo trial also did not show this. Cyclophosphamide continues to be the number one drug. But you could use rituximab in many patients of membranous nephropathy, predominantly if there are contraindications to the use of cyclophosphamide. Otherwise, I think at the moment, predominantly modified Ponticelli regime. And which are the patients where you will feel Ponticelli regime would be the drug
Where
you
there
will
is-
use? And which patients will you choose? She is a lady, 27 years, how many pregnancies?
One pregnancy.
One pregnancy, okay. So what will be the decision of not using cyclophosphamide in this patient?
So whether if she is planning for further pregnancies, then I will try not to use cyclophosphamide, though I will give her both the options.
What is the dose of cyclophosphamide which you use which cause
ovarian
ovarian failure?
10 grams.
10 grams. What's the dose of cyclophosphamide you are going to use in your therapy with the modified Ponticelli?
2.5 mg per kg. Modified
Yeah.
Ponticelli. Like
Yeah.
2.5 mg per kg.
So how much would be the
month
cumulative dose? You will give it 3 months?
3 months, yes.
3 months.
2, 4,
So
6.
2 milligrams per kilogram body weight or 2.
Cumulative dose will be much less.
Yeah. So cumulative dose will be.
She's planning for the second pregnancy. I mean, some.
She might be keen on second pregnancy. That's why she said that.
No,
she might.
She was planning. I mean, she was planned to have or any.
No.
No.
First she had an abortion and then after 5 months she conceived.
She conceived one baby. So the dosages are unlikely to get into those dosages of. And what level does the malignancy?
36.
So 30 grams or so. So these are dosages which are unlikely to be reached by our regimens usually.
So she had a stable renal function on presentation. Creat was pointed. I would have considered modified Ponticelli if there is a worsening renal function or something like more severe disease.
Yeah.
Now the creatinine is rising to 2.4. Why should you not consider modified?
They are planning to give her a modified Ponticelli now, from.
Yeah, so you would consider this in severe. Those patients, any other, now that you have PLAR also available, is there classification of based on the PLAR levels or titers?
More than 150 RU per ml is considered high risk for
very
progression.
high titer, which is unlikely to respond to rituximab. So it's more likely to respond to cyclophosphamide. Out of these drugs, which will produce reduction in proteinuria, out of the various drugs which are available, you have a patient who is severely nephrotic. So cyclosporin and all, and then cyclophosphamide and then rituximab. Rituximab takes usually 4 months for reduction in proteinuria or a significant reduction in proteinuria. So 4 to 6 months. So it takes longer time to produce or induce. So what is the indicator by which you can predict will your therapy produce remission or not? How do you monitor these? Nowadays you have all these capabilities. We would never know previously would this patient ultimately achieve remission or not. But these days there may be a marker by which you can what
markers, biochemical markers, like low titers of anti-platelet or antibodies if they are positive.
In treatment. Suppose you give treatment, now how do you monitor? You can within a month or two you will be able to know whether
reduction in the proteinuria.
No, reduction in proteinuria might take 4 months, as I said.
What is
PLAR2 antibody itself. When you have, so you should look at PLAR2, reduction in PLAR2. When you give these therapies, both cyclophosphamide and rituximab, usually you will have 60% reduction in PLAR2 antibody within 1 or 2 months. And those who have more than 60% reduction in the PLAR2, they are very likely to go into a remission, a longer lasting.
The only problem is if you don't have a PLATVAR positivity.
Yeah, that's it. Yeah, it's only those who are serologically positive. It is about 67, 60%.
70%.
Yeah, 67%. So PLAR2 can be used not only for diagnosis but also for monitoring therapy in these patients. And there are patients who achieve very quick reduction and if they also achieve a reasonable reduction in proteinuria, you can in fact stop therapy and you may not continue therapy for 6 months or so. If you have achieved an immunological as well as a clinical remission, quickly you don't need to continue therapy in these patients. So that's
even rituximab also is associated with high incidence of relapse following withdrawal of rituximab. I mean, there
30-40%. Yes.
Yes. So it's a very expensive drug, but a high incidence of relapse. That's the problem.
So if you have treated the patient, the PLATVAR became negative. On follow-up, you just did for a follow-up, PLATVAR is increasing again. What do you think?
If I have used initially rituximab, then I will use either.
No, what you will do? You start investigating or increase the immunosuppression, or you wait for the proteinuria to reappear?
I will start investigation, sir. I will address and I will try to treat if PLA are rising.
No, his question is, what will be your target, proteinuria or PLA2R?
I don't know, sir.
we at the moment there are two thoughts about it. There are clinicians who will say they will not only
Reduce
treat
the
blood
don't
too.
reduce, yes.
So they may not reduce immunosuppression. They may continue the immunosuppression for a longer time. Monitor these patients more closely. But there are people who might say that if
Give
we,
one dose of
they might say that they will check two levels of blood. If one is gone up and the second one confirms in about 2 weeks to 4 weeks that the titer is going up, then they might give another rituximab at that point of time in these patients. So these are the patients.
Similar with ANCA-associated vasculitis.
Yeah.
Whether we'll treat ANCA or disease relapse, same thing. We are not here, I mean, it's not that we have reached a conclusion, but we have to reach a conclusion. Time will tell.
Yeah, fortunately in membranous there are a lot of people who are working on these therapies and using these newer markers to identify. So you are getting evidence, more and more evidence every day about the use of these markers, both not only for diagnostic purpose but even for helping you to monitor how you should monitor these patients with the use of these newer diagnostics. So NEL1 is become available in the West that you can do it serologically. Unfortunately, at the moment we do not have NEL1, and other semaphorins and others are also not yet available serologically. So you have only PLA2 which is available. So you can do it at least in about 70% of your patients. I think that's it. Thank you.
Thank you, sir. Thank you, sir.
Okay.